We can then start with our meeting. I know for members it's a bit strained today because we don't have any sittings this week, and therefore if we would have been wiser in advance, we would have converted or had this meeting as virtual, because I've seen most committees are sitting in our own virtual. It's only us and sports that are physical. The rest of the committees are on virtual sitting. But I always say most critical matters or issues that requires that we focus and give full attention without being distracted requires us to have them in person and in physical, so that we're able to deal with them. And the matter of state patients that are incarcerated in correctional facilities, it's a serious matter that required us to even have this meeting today. So my name is Khomotso Enthia Ramolobeng. I am the Portfolio Committee Chairperson. Members, you have the draft agenda before you. Before we could even begin to go through introductions, let's start with affirming the agenda for today's sitting. Honorable Niehaus.
Thank you, Honorable Chair, and I greet the representatives of the Department of Correctional Services and Health, and also my fellow colleagues. I propose adoption of the agenda. Thank you.
Honorable Klute.
Thank you, Honorable Chairperson. I second the mover for the adoption of the agenda.
Thank you. The agenda is duly adopted and serves as a guide for today's meeting. You are all welcome to today's Portfolio Committee meeting. In actual fact, today becomes the last quarter meeting for the Portfolio Committee, as members would be going to recess. So this makes us to have our last quarter meeting, which is physical. I would therefore request that we start with introductions. And let's not assume that we know each and every person that is in the room. And I think I'm doing that also for my sake. I seem to have misplaced my glasses. So you will pardon me as the meeting proceeds. I might not be able to see some of you because I can't see far. I can't see the projector. So I am a bit partially blindsided today. So I would request, I'm making an apology in advance if instead of saying Niehaus, I'll say Engelbrecht. You'll just pardon me. I don't have my glasses with me today. As I indicated, my name is Khomotso, colonial name Enthia Ramolobeng, a member of the Portfolio Committee and trusted by the committee to be the chair. We have Honorable Engelbrecht. We have Mrs. Ngaba. We have Honorable Niehaus. We have Honorable Taibosh. We have Honorable Hendricks. We have Honorable Muela. We have Honorable Sokopo. We have Honorable Klute. We are supported by Mrs. Nomandla and Ms. Sowazi. The fellow at the back there, I'm told, is a journalist, is not supporting our team. So he will then introduce himself. We are therefore supported by the content advisor, Mr. Matabata. And we have been missing For the longest time, I think since the ad hoc committee started, the media liaison officer, Ms. Raja, welcome. It's good to have you back. You have been missing in action. I realized that you are back when today I was bombarded by media requests of interviews. I knew that Raja is now fully back. The ad hoc committee has concluded its work. It's good to have you back. And it was quite difficult to go through Ramadan without you in that whole month, giving support to the ad hoc. Then lastly, we have the committee secretary, Mr. Mtonjeni. I will hand over to the National Commissioner. You are leading the delegation on behalf of the TCS. You will then do the introduction of your team, then we'll take it to the Department of Health, and then we'll wrap it up with JICS. And after JICS, we'll then have others who are not listed from departments to introduce themselves. National Commissioner.
Thank you, Honorable Chairperson. Thank you, honorable members of the Portfolio Committee. Our delegation is consisting of the following officials. We have Ms. Mulepo, who is the Chief Deputy Commissioner responsible for rehabilitation. We have she is with Ms. Matsize, who is an acting director, non-communicable diseases. We have Ms. Ramulifu, who's the Chief Deputy Commissioner responsible for remand detention. We have Dr. Musoma, who's the Deputy Commissioner responsible for the Office of the National Commissioner. We have Chief Deputy Commissioner Katenga, who's responsible for strategic management. And then we have Mr. Mdluli, who's the acting director, EST. We also have Mr. Ngumalo, who's the director communications internal. And then we have Mr. Fakude, who is in the office of the deputy minister. Yeah, Honorable Chairperson, I think I've introduced everybody. My name is Mahoti Samuel Tubahale. I'm the National Commissioner of the Department of Correctional Services. Thank you, Honorable Chairperson.
Thank you, National Commissioner. Department of Health.
Good morning, Honourable Chair. Good morning also to all the honourable members. Let me start off by introducing myself. I'm Nicholas Crisp. I'm the Acting Director General, and my substantive job is that I'm the DDG for National Health Insurance in the National Department of Health. Let me also apologize for our Minister, who's got meetings with people abroad in preparation for a trip that he's travelling abroad on Monday. I'm with Dr. Dudu Shiba on my right-hand side. She is responsible for mental health in the National Department of Health. I'm also with Mr. Khatla, who is the Parliamentary Liaison Officer for the Department, who's sitting behind, and Mr. Mchiza, who is in the Office of the DG in the National Department of Health. Thank you very much.
Chicks.
Good morning, Honourable Chair, Honourable Members, everyone else present. I'm Lee Bozilek, the Inspecting Judge for JICS, and I'm going to ask my JICS CEO, Mr. Vic Misser, to introduce the various members of our delegation. Thank you.
Good morning, Honourable Chair and Honourable Members. It's pleasing to be back here in the House. We greet you all. Also, the National Commissioner, we greet you, and we also greet the Acting DG of the Department of Health. My name is Vic Misser, and accompanying my team Directly behind me is the acting regional head of regions for us, Madam Gerika. Next to her is the researcher in the judge's office, and that's Madam Mchali Mpo. Directly behind him is the head of investigations and inspections, Mr. Leonard D'Souza. Next to him is the head of corporate services, Mr. Eddie Brewers. And to my left is the researcher in the IJ's office, and that is Madam Nina Lang. Thank you.
Thank you. The fellow at the back there on the right.
Okay, my name is Sivuile Mazansi. I'm a freelance writer.
If you could speak through the mic.
Okay, can you hear me now? Sivuile Mazansi is my name. I work as a freelance writer. Thank you.
Did we get? Okay.
I think, can you hear me now?
Yes.
Yes, my name is Sivuile Mazansi. I work as a freelance writer. Thank you. I'm a freelance journalist.
Okay. Which media house?
I don't represent, when you work
You are
as a freelance-
freelancing?
Yeah, I'm freelancing.
Okay.
Yeah.
Thank you.
Thanks.
At the back, did they introduce you? Oh, I said I don't have my glasses today, so I did give an apology.
That's okay, Madam Chair. I'm just with chicks
Okay.
sitting here. Thank you.
Thank you. Thank you so much. At least we now know who's in the room. There's a serious change. Ms. Ngaps, today we have Queen straight no Pumala. Mr. Mtonjen, apologies.
Morning to the meeting, morning to yourself, Chair. We've got quite a few apologies today. The acting DG has already alluded to the apology of the Minister and the Deputy Minister of Health. From the Minister and the Deputy Minister of Correctional Services also tendered an apology, Chair. From our members, Honorable Shangase is not well, Honorable Gasa is attending classes, and Honorable Nolu Chungu is committed due to political commitments, could not make it for today's meeting. Thank you, Chair.
Thank you. Honorable Gasa and Honorable Noluchunga attending classes which started yesterday. They are concluding tomorrow. It's blocked classes. That's why they are not here. And speedy recovery to Honorable Shangase. And including the Deputy Minister of Correctional Services. She's also not well, so we wish the Deputy Minister of Correctional Services and Honorable Shangase a speedy recovery. Members will take the apologies as noted, even though DDG do pass on the message to both the Minister and the Deputy Minister that there was an expectation that either between the two become part of the meeting, so that whatever decisions or recommendations that gets to be given in this meeting, they are the custodian to make sure that there is execution of them. So we do note the apology, but there was an expectation of them being part. Perhaps if we were alerted earlier, we would have rescheduled the meeting, considering their diaries or either one of the two in terms of their availability. But we'll therefore move to item 3 of the agenda, a briefing by the Department of Health on all the listed requests that we've put to the department on state patients that are incarcerated in correctional facilities. And we've seen also a number of letters or formal letters written previously by the then inspecting judge, Judge Cameron, representing JICS to the Department of Health on accountability and when are those who are found in correctional facilities being moved. I think when you do take us through the presentation, also try to come back and tell us what is it that you have done formally from those requests that you've received from JICS. So I'll hand over to yourself, DDG, to take us through. Thank you.
Thank you very much, Honourable Chair. So first of all, an apology that we sent a slightly amended version late yesterday. There were just some spelling mistakes that we had to correct and some just minor changes to make things clear on slides 10 and 11. But there are no additional slides or no substantive changes to anything in the presentation. I'm going to ask Dr. Sheba to do the presentation since this is her substantive portfolio, and then we'll both be taking questions and answering those questions. Thank you.
Thank you. Good morning, Chair, honorable members, National Commissioner, and colleagues. I will just go straight to the slides. The first slide is just an outline. As a background, Chair and honorable members, we started by defining the concept. A state patient is an accused person who has committed a serious crime, but is declared by a court as unfit to stand trial or not criminally responsible due to mental illness or intellectual disability, and an order that is issued by the court in terms of the Criminal Procedures Act as amended. Previously, courts were only able to order that accused found not to be criminally responsible in terms of Section 78 or of the Criminal Procedures Act, or not capable of understanding the proceeding so as to make a proper defense in terms of Section 77 of the Act as amended, be declared a state patient. The Criminal Procedure Act was amended to provide the courts with an option to order that a person be admitted as an involuntary mental health care user in terms of the Mental Health Care Act, rather than the state patient in case of minor offenses. The slide is looking at the legal framework regulating the detention and management of state patients in the country, which is first the Criminal Procedures Act, which makes a provision for courts to declare an accused person a state patient based on the evidence presented, including the forensic mental health inquiry report by a designated suitable mental health expert. Also makes a provision for a state patient to be temporarily detained in a correctional health facility when a bed is not immediately available in a psychiatric hospital. Then we have the Mental Health Care Act as amended, Chapter 6, which provides for, first and foremost, designation of health establishments for state patients, prescribes the procedure for admission of state patients to designated health establishments, transfer of state patients between designated health establishments, and application for discharge or reclassification of a state patient. It also prescribes a procedure to deal with state patients on leave of absence and those who abscond. Provides for periodic reviews of mental health status of state patients. This slide is indicating that in the management of state patient is a collaboration between a number of departments. The first one that we are listing there is the Department of Justice and Constitutional Development. The courts make an order declaring an accused a state patient. For minor crimes, the court have a discretion of making an involuntary mental health care user order instead of a state patient. Then there is Correctional Services, collaborate with the relevant prosecutor and investigating officer to ensure that where a court directs that an accused be admitted as an involuntary mental health care user, such a person is sent for admission to any of the 64 hospitals that are designated in terms of Section 5A of the Mental Health Care Act. Temporarily detain a state patient when a bed is not immediately available in a psychiatric hospital. Make arrangements with SAPS for transfer of a state patient to health establishment as soon as the bed is made available. Then there is a National Prosecution Authority. When the head of a health establishment makes an application to a judge in chambers for discharge or conditional discharge or reclassification of a state patient, the responsible prosecutor makes recommendations to the judge in chambers on whether the application should be granted and the basis for the recommendation. We then have the South African Police Services, whose responsibility is to transport state patients between the court, the DCS facility, and the designated psychiatric hospital, and also to apprehend and return to a health establishment a state patient that abscond. Then we have a Department of Health, designate health establishment for state patients and admit state patient as soon as the prescribed administrative process is completed and a bed is available. Authorize interfacility transfer of state patients, conduct periodic reviews, consider and approve periodic reviews reports of state patients, make applications to a judge in chambers for non-conditional discharge, conditional discharge, or reclassification of a state patient, and ensure proper follow-up and management of state patient on leave of absence or conditional discharge that are in the communities. There are 14 health facilities with a capacity to admit state patients in the country. All provinces, with the exception of Mpumalanga, have at least one of such facility. The tables in the next two slides provide a breakdown of the facilities by province as well as the number and distribution of state patients. In this table, Chair and honorable members, we are breaking down the numbers by province and by facility in each province. So it is also meant to already show how many facilities does each province have. Eastern Cape has got 2 facilities, that is Fort England and Komani. These numbers are as of 28 February, as we have not yet consolidated or ended the month of March. As of 28 February, there were that number of state patients that were with us in the Department of Health. Fort England had 406, Komani had 323, Free State Psychiatric Complex 183, Gauteng, Weskopis and Sterkfontein 307 in Sterkfontein and 251 in Weskopis, KZN 457 in Fort Napier, 150 in Madadeni and 65 in Umzimkulu, Limpopo 244 in Hayani and 234 in Tabamopo. Alongside, we also capture the number of state patients waiting in DCS facilities as of 28 February again, as well as in the last slide, the number of new state patients that these facilities admitted, and the numbers are reflecting them, showing how many were waiting as of the end of February and how many were admitted, with the totals in the next slide. It is showing there that Mpumalanga has no facility. The temporarily get from time to time assistance from Vescopis, and there were 38 state patients in Mpumalanga correctional facilities waiting for admission. And those are the other figures that shows in total the 14 designated facilities in the country, and they're showing that those that were with the Department of Health, we were standing at 3,415, and as of the end of February, those that were waiting were 437, and from April to 2025 to February 2026, 11 months, we had admitted in 339 new state patients into our designated health facilities. And in these slides, we are capturing challenges that result in delays to admit state patients to appropriate health facilities. The first challenge there is the courts have a tendency to declare patients with minor offenses by definition as state patient. There is also a delay by the courts to grant discharges and or reclassification of state patients, causing the throughput challenges. The plans to address this challenge is the Department of Health needs more resources to be able to create more space for state patients. And the second one is we are strengthening intersectoral mental health forums and close working relationships among stakeholders, including the courts and prosecution. This has begun, and as a result, the situation is gradually improving in terms of that challenge. Limited space in designated psychiatric hospital with capacity to admit state patients, largely due to infrastructural disrepair, is the second challenge. What the Department of Health is doing about this is that provinces have been urged to prioritize infrastructure repairs and revitalization projects, especially at Komani and Elizabeth, Donkin and Fort England in Eastern Cape, as well as Sterkfontein Psychiatric Hospital in Gauteng. Plans to build a specialized psychiatric hospital in Mpumalanga are underway, and plans to add another state patient ward at Umzimkhulu hospital are underway. The Department of Justice and Correctional Development has not been paying the Department of Health for forensic mental observations conducted since 2023. The amount of 380 is currently outstanding. The DOH continues to use its resources for this service that it is not funded for. And the next one is the refusal by families to accept the persons after discharge. For this problem, the plans that we are implementing is to identify a responsible family member early and involving them in the treatment process, admitting the person as nearer home as possible to facilitate the regular leave of absence, strengthening public education on mental health issues, including messages on treatability of mental disorders and anti-stigma messages. The cross-border issues, especially Umzimkhulu Psychiatric Hospital, which is between KZN and Eastern Cape. Eastern Cape and KZN are working on a memorandum of understanding to address the cross-border issues and strengthen collaboration. The next one is the issue of the shortage of mental health clinical experts that are required in rendering this highly specialized service, especially in rural facilities like Komani, Umzimkhulu, and Hayani. The plans, there are the South Africa has 942 psychiatrists as per the HPCSA registers. And about 75 to 80% of these specialists are working in private sector, while the majority of patients are being attended to in the public sector. The equitable sharing of resources between private and public sector in a manner that is envisaged by the universal health coverage is the core of the solution to this problem. In the meantime, various interventions are being implemented to address shortage of psychiatrists and other members of the multidisciplinary team through the Department of Health's Human Resource for Health strategy. Through these efforts, among others, a psychiatrist was appointed for Komani after some time struggling through headhunting and started in June 2025. The increase in the number of people that are declared state patient is one of the problems as well. And substance abuse is the main driver alongside the general increase of crime and the incidence of other mental disorders. The Department of Health feels strongly that the country is not strong enough in combating criminal syndicates that are peddling drugs in the country. The amount of freely available illicit substances in the country needs to be addressed. The use, e.g., of crystal meth makes users psychotic and extremely violent, and these are the kinds of person that families and communities do not want back after they have been treated and rehabilitated. Strengthening access to mental health services in communities and primary health facilities to strengthen early identification and treatment and management of chronic mental health care users that are in communities, and strengthening defaulter tracing through the use of community health care workers, and a whole society approach in promoting mental health and addressing the risk factors that drive psychiatric morbidity at the main and including substance abuse is being applied and should be further strengthened. With that, the recommendation is that the Portfolio Committee on Correctional Services note this report on declared state patient, the challenges that are resulting in delays to admit state patients in appropriate health facilities, as well as the plans to address the identified challenges. I thank you.
Okay, thank you very much, Madam Chair. So if I can just add a more generic comment to the presentation. I don't think the public and some of the members of parliament follow just how difficult it is to run a department where the provinces run the services. So it's not the National Department of Health who runs any services. We don't have the budget, we don't give them the budget. They get their budget through their provincial equitable share. So it's a constant negotiation and discussion with each of the provinces, and they have their own problems, their own challenges, their own other services they have to deal with. So sometimes priorities from one province are not the same as another one. And so they will push back, as you heard, between Umzimkhulu and the Eastern Cape, where their budget is limited, so they're not in a hurry to admit a patient who comes from across the border in another province, even though we are all citizens of the same country. It's a tension that we must recognize, and we from the National Department then try to plug the gaps using whatever means are at our disposal. So it was mentioned that Mpumalanga has never had a mental health facility at all, never mind for state patients. So at the moment, we are having to accommodate patients that come out of Mpumalanga into other provinces, primarily Gauteng, which is not ideal because then they lose touch with their communities and their families. So you may recall the President announced some projects in the SONA address, and one of the 11 national infrastructure projects is the building of a new mental health care facility in Mpumalanga. So that has been submitted as part of the BFI project for this coming cycle, but as you know, it'll take a while and some years before we get to that point. So there are plans afoot, but we are under serious strain. Thank you.
Thank you so much for the presentation. And we hope that the building of the new facility does happen anytime soon. I think it has been in the pipeline since 2022. We are now in 2026, 4 years later. We are still speaking about it. Has the numbers of state patients incarcerated in facilities changed, National Commissioner, based on the latest stats that we have, or still remains the same?
Thank you, Honorable Chairperson. The numbers that we have are as of January 2026. Our total is 401. Those are the numbers that we have in the information that is in front of me. We obviously are noting that the numbers from the Department of Health are as of February 2026. So we just need to do a quick reconciliation on the matter.
Okay. Thank you so much, because it's very important that we make sure our numbers talk to one another. Members, any questions, clarities that you'd want to pose? Honorable Engel, Honorable Ngaba, Honorable Niehaus, Honorable Moela, Honorable Sokopo, Honorable Taibosh, Honorable Hendricks, Honorable Klute. In that sequence. Engel, I know you drafted your questions from last week.
Yeah,
I hope they were not added.
Thank you, Madam Chair. Only 9 questions this time. Our collective goal must be that no state patient ever sets foot in a correctional facility. Does the Department of Health share this goal? And if so, what plan and timeline do you have to make that a reality? When Correctional Services talks about lack of beds, they mean that they have no space in severely overcrowded facilities. When the Department of Health talks about lack of beds, they mean no space in a psychiatric hospital, or there's too few psychologists to be assigned to these state patients. The result is that mentally ill people are held in cells that's not designed for them. How do you propose we bridge this gap so that a bed shortage in the health system no longer automatically becomes a crisis in the correctional system? Suicide is the leading cause of unnatural deaths in correctional centres, often linked to lack of supervision and overcrowding. How many state patients have died in correctional custody while waiting for a bed in a psychiatric facility? And what message do you think it sends when we continue to use prisons as de facto psychiatric wards? It is noted from the DCS annual report that as of February 2026, there were 401 state patients held in correctional facilities. Can you confirm that this number aligns with the Department of Health's own data? And how many of these 401 individuals are currently awaiting placement in designated health facilities? The committee is aware of the Constitutional Court judgment in the Foss NO and others versus Minister of Justice and the amendments made to the Criminal Procedures Act. Despite this, the number of state patients in correctional centres has increased significantly. Why is the department still unable to comply with the law by transferring these patients to designated health establishments? Your presentation indicates that Mpumalanga is the only province without a designated psychiatric hospital for state patients. The committee was told in 2022 that the plans for construction were underway. It is now 4 years later, and you said exactly the same thing. What exactly is the current state of that project? And what are the remaining challenges? It is noted that accused persons often wait over a year in a correctional centre just to begin their 30-day forensic observation. What is the current national backlog for these forensic psychiatric assessments? And what specific measures are you taking to clear this backlog? JICS warned in 2025 about the risk of litigation over the incarceration of state patients. What direct engagements have you had with DCS and the Minister of Justice to resolve the waiting list crisis and prevent legal action against the state? The committee's research indicates that the Department of Health has not been paid by the Department of Justice for mental evaluations since 2023. Is this accurate? And if so, what impact has this lack of payment had on your ability to conduct observations and process state patients? All from my side, thank you.
Thank you so much, Honorable Engelbrecht. Really, you didn't add anything. They are the same as the last week ones. Mrs. Ngabs?
Thank you, Chairperson. So I think Honorable Engelbrecht has gone into a lot of details, and I'm sure my colleagues will as well. I have, let's call it one question clustered, and it is a big picture question. So Dr. Crisp, you are a medical professional, so is your minister. You guys oversee our whole health sector. I think I can call you the custodians of the Hippocratic Oath, do no harm. And right now we have ill people who are locked up in prisons. My question and my submission, would you agree that keeping state patients in prison is extremely harmful? I would also ask you, would you agree that we need to move all state patients out of prisons into hospitals immediately? And if you don't agree with that, I would ask you why. So based on the presentation, and thank you, it was helpful for some context. So you have potentially very, very dangerous people who are state patients, but nevertheless, they can't be convicted. They are not convicted violent criminals. And the reason they couldn't be convicted is because they're not well. So they don't, even the violent ones, don't belong in prison. And then on top of that, based on the presentation, we see more and more petty criminals being classed there incorrectly. So actually some of those people, even if you said violent criminals should be there, they still shouldn't be there because they're not violent, it's petty crimes. I would argue, and it sounds to me, all of this is incredibly inhumane, it is incredibly indecent, it is inconsistent with our constitution. And I also just want to point to numbers. So acknowledging the discrepancy in the numbers, if we use your figures, the state patients who are waiting in DCS facilities, plus the new state patients admitted into hospitals is about 776, right? And I actually don't know why I'm adding the new ones. Let's work on 437. If you were to increase the current hospital population by all the guys who are in prison, it's just over 10% increase, right? So you would then have these 400 people who are locked up with an extra 3,400 sick people. The alternative to that, what's currently happening is you have these 400 people currently locked up with 150,000 other people, many of them violent and dangerous. If in the land of trade-offs, we can either take these 400 people and put them with 150,000 criminals, or we can take these 400 people and find space for them with 3,000 other patients. How is keeping them in prison the middle ground that we've settled on? How is this correct? I don't understand. Could you walk me through your reasoning in terms of, do you agree that the state patients need to be moved to hospitals immediately?
Thank you so much, Mrs. Naps. Honorable Niehaus.
Thank you, Honorable Chair, and thanks to the Department of Health for the PowerPoint presentation that they have given us. I sincerely hope that the absence of the Minister and the Deputy Minister of Health is not an indication that this matter is not taken as serious as it should be. I would like to reference the Department of Health to the 2015 Divorce Constitutional Court judgment, which very clearly indicated that the incarceration of state patients in correctional services facilities is in fact unconstitutional and a human rights abuse. So that is how serious the situation is. That seriousness of the situation has been acknowledged by JICS, and JICS has indicated the very strong chance of legal action to be taken about the continuing incarceration of state patients. Now, Chair, I need to state unequivocally, and I've said so before when we discussed this issue, that the position of my party is unambiguous and non-negotiable. The EFF is clear that it is both immoral and illegal to incarcerate state patients in prisons. I'm sure that the Department of Health will agree with me that prisons are not therapeutic environments, and to detain state patients in prisons violates the rights to dignity, to freedom and security of the person, and access to adequate health care for these patients. It directly contradicts the Mental Health Care Act's mandate to transfer state patients to designated health establishments. As I've said, it is a rejection of the divorce judgment, and it is a rejection of the fact that these state patients should be kept in mental health institutions and not prisons. Thus, the continuing warehousing of hundreds of mentally ill people in totally unacceptable and improper correctional centres constitutes cruel, inhuman and degrading treatment, and definitely exposes the state to future litigation, which I believe will be successful. Capacity shortages, court delays or substance abuse trends, as much as they can be advanced as reasons for the situation, are certainly not excuses. At the end of the day, they are symptoms of chronic underfunding and of political neglect. Therefore, the EFF's position is clear. Every state patient must be removed from the Department of Correctional Services facilities immediately. and be placed in appropriate, well-resourced mental health facilities. Let us underline this. Anything less is a betrayal of our constitutional obligations. And understanding that is critical, and I fear that the PowerPoint presentation that we received from the Department of Health does not understand that reality. They treat this ongoing constitutional crisis as a so-called manageable delay rather than an emergency. They talk to us in this presentation about vague long-term plans to replace concrete, time-bound, and funded action. And we reject, as the EFF, this normalization of illegality. Now let me ask my questions. First of all, with reference to the divorce judgment, given that the Mental Health Care Act and that judgment explicitly requires state patients to be in designated health establishments, not in prisons, why does the National Department of Health continue to describe 437 people languishing in correctional facilities as a mere challenge, instead of an illegal and immoral human rights violation that should end forthwith? There's also the discrepancy between the numbers that we got from the Department of Health and the Department of Correctional Services. It's not acceptable. These numbers should have been consolidated before this presentation before us. And we need to get a national commissioner. You said you're working on it as you sit there. We need to get all the figures as a consolidated agreement between the two departments. In the EFF, we reject any temporary detention loophole that may exist in the Criminal Procedures Act. And we must ask, why has the National Department of Health not approached the courts and the Minister of Justice for an urgent national directive to stop all further declarations of state patients into Department of Correctional Services facilities until sufficient psychiatric beds are available? You refer in your PowerPoint presentation about the dragging on situation in Mpumalanga, where there's still no psychiatric hospital. When will construction now actually begin? And why has the Department of Health not fast-tracked a temporary forensic psychiatric ward in the province to prevent any further imprisonment of the residents of that province? The National Department of Health admits a 380 million is owed by the Department of Justice and Constitutional Development for forensic observations since 2023. You continue to provide this service unfunded, I understand. But why has the department not withheld services or approached the courts for an urgent interdict until this debt is settled? Surely this is an emergency, given that non-payment directly contributes to prison backlogs. The documents show a 9.7% increase in state patients over 5 years, and a sharp rise of these state patients in the Department of Correctional Services facilities. What specific ring-fenced budget allocation and bed creation target has the National Department of Health secured from the National Treasury for this current financial year to eliminate the waiting list entirely? As I've already indicated, the EFF views the continued incarceration of state patients as a form of cruel treatment. I've got no doubt that their presence in prisons drive up suicides and violence in prisons. And what immediate mental health screening and diversion protocol has the Department of Correctional Services implemented to identify and urgently transfer all current state patients, and why has this not been done already? The National Department of Health presentation, this PowerPoint presentation that we have received, blames our courts for declaring people with minor offenses as state patients. But does the department accept that the actual real failure lies with the state's chronic underfunding and community-based health services? And when will it now actually table legislation or regulations to prevent such inappropriate declarations? I've already referred to the fact that JICS has warned of imminent litigation against the Minister and also the National Commissioner. Here's my question to the DCS. What concrete steps have you taken since October 2025 to release or transfer every state patient whose detention is now unlawful? And will the department commit today to 0 state patients in our prisons by the very latest, the end of 2026? From our standpoint in the EFF, mental health care is non-negotiable. It is a constitutional obligation, not a plan, not a forum, and the Ministers of Health and Correctional Services should table to this portfolio committee within 30 days a joint emergency implementation plan with quarterly publicly audible targets to remove every state patient from the prison system and house them in appropriate facilities. And if you say you can't do so, why should Parliament not hold both your departments in contempt for perpetuating what is an unconstitutional practice? What is the current national backlog for the 30-day forensic psychiatric observations required under Section 79 of the CPA? And how many accused persons are currently detained in correctional services awaiting even the start of this critical assessment? How many foreign national state patients are currently held in DCS facilities? And what specific diplomatic and repatriation arrangements have been made to ensure they are not indefinitely warehoused in South African prisons? Given that suicide remains the leading cause of unnatural deaths in correctional centres, what mandatory mental health screening and urgent diversion protocols have been implemented for all new admissions and existing inmates to prevent state patients from being held unlawfully? Let me conclude, Chair. The EFF will not accept another round of PowerPoint slides. There's been previous presentations in the previous administration by the Department of Health and the Department of Correctional Services. I've gone back to those presentations. They are not substantially different from what we received today. The continued incarceration of state patients is not an administrative inconvenience. We must see it for what it is. It is an ongoing constitutional crime against vulnerable South Africans. The data that you presented to us today tell me only one story, and that is that the system is collapsing under its own neglect. And as a consequence, hundreds of mentally ill people are rotting in cells with ballooning numbers, unpaid bills, missing provinces such as Mpumalanga, and litigation warnings such as had come from jigs already on the table. So here's the demands from my party. It is urgent that we declare a national emergency and transfer every single state patient out of DCS facilities forthwith, but at least within the next 90 days. That we table a ring-fenced emergency budget of no less than 1 billion for new forensic beds and infrastructure. And at least this plan must be tabled before the end of this quarter. That we introduce urgent regulations to prevent courts from declaring state patients for minor offences until community mental health services are adequately funded. And that we get published monthly, publicly verifiable dashboards showing the number of state patients that are still in prisons, the beds that are being created as that process goes on, and the transfers that are completed. That we hold the Ministers of Health and Correctional Services, and that's why I find it so unfortunate that the Minister of Health is not here, also the Minister of Correctional Services, although we have received apologies that seem to be acceptable, but that we hold these ministers personally accountable through quarterly appearances before this committee until the prison population of state patients reaches the number that it should always have been, which is 0. Chair, my party will not rest until every state patient is removed from South Africa's prisons and placed in humane and therapeutic care. This should not be a negotiable. And we as members of Parliament have a responsibility to implement the Constitution. What is happening with state patients is unconstitutional. It is in contravention also of the oath that we lay down as members of Parliament. If we accept or allow this unconstitutionality to drag on, we must act now, or otherwise we are co-responsible for the violation of our Constitution. Thank you, Chair.
Thank you so much, Honorable Niehaus. Honorable Muela.
Thank you very much, Honorable Chairperson, and thank you very much for the presentation from the presenters, and also let me acknowledge Jigs in the meeting, the judge and the CEO, and also the NC and the team, and also express your views, Honorable Chair, in terms of our expectations from both Ministers of Health to be present in this meeting, because the issue of the state patient is a very crucial matter that needs an urgent attention, so that we are able to ease the contradictions and the problems that we are facing in our centers, most particularly when we come to the issue of overcrowding. So it was very much imperative that they were part of this meeting, so that we have a way forward, because we have been expecting their presence here. So, and also let me start by entering on my questions, Chair. I want to check with the presenters in terms of what is an ideal security system that we are having in our psychiatric hospitals that housed state patients. How are they ensuring their safety and security? What is an ideal security system that they are using? And also to check in terms of their safety and security, who is responsible to ensure that they are safe, there is no escapes or anything that is happening? Is it Department of Health or what? And in terms of foreign nationals, how many do we have in our facilities who are state patients? And also, I want to check with regard to Tabamopo psychiatric hospitals. For the past 6 years, was there any escapes that have been reported in that hospital that we can know of? Tabamopo is one of the hospitals in Limpopo. Honorable Chair, we cannot also ignore the reality that continued detention of state patients in correctional centers contributes directly to overcrowding. How is the department working proactively with DCS to reduce overcrowding by accelerating transfers and improving mental health system responsiveness? Could the department clarify whether its recommendations are supported by clear implementation plans, timelines, and budget allocations, and how it will ensure that these do not remain high-level proposals without tangible impact? Additionally, Chairperson, the current legal framework does not even clarify or clearly define mental illness, and it appears to contribute to systematic inefficiencies. What progress has been made in engaging with the Department of Justice on reforming the Criminal Procedure Act, and how will these reforms address the ongoing waiting list crisis for psychiatric health evaluations? On the issue of the warning from the JICs on the potential litigation due to unlawful or prolonged detention of state patients, what measures is the department taking to mitigate legal and human rights risks associated with the continued detention of state patients in correctional facilities? And has a full audit been conducted to identify potentially unlawful cases? That will be my questions, Honorable Chair. Thank you very much.
Thank you so much, Honorable Moela. Honorable Sokopa.
Thank you, Chair, and greetings. Let me also take the opportunity to thank the department for its submission. Chair, I have a few questions. The presentation was talking about temporary detention, and I concede that the law do make provision for that. But let's go and check practically whether are they really there temporarily.
And I would have loved the Department of Health to tell what is temporary to them, the duration that you consider as temporary, what does it mean? Because you would have a situation where you have inmates or state patients that are incarcerated depending on their appearance in court. So if, and that's an assumption I have, if there is a bed at Correctional Service or there is no beds any case because Correctional Service is overcrowded. But if they are incarcerated there, whether there is a bed or not, it does not become a problem of health. And if it does, I would appreciate if health can say to us here, in a financial year, this is how many state patients we went to fetch from Correctional Service into our facilities, whether it's per province or so, just to show that there has been an effort of you going to Correctional Service and say, by the way, thank you for hosting 5 of our people, we are taking them back. There has been an increase on the state patients. What would have been an intervention? I think, Chair, if the Department of Health would have attended to the matter, let's take Mpumalanga for instance. It can't be correct that you say, no, but there is no psychiatric hospital in Mpumalanga and therefore we are taking people to any other province. Instead, like Honorable Niaus was saying, instead, or I don't know who was it if it was not him, instead of saying that this is a provision we are making to make sure that we host these people in their province so that they would not be far, like the acting DG was saying, that they are not far from their families, because part of these people would have need love, care of their people. Imagine their people would have to travel 300 plus kilometers to go and see their people. And I'm sure the inmates or the state patients themselves, it would have a psychological effect on them if they are not interacting with their loved ones. I have stated the issue of where people are staying more than a year or so. Your observation period takes 30 days. What is the current national backlog for forensic psychiatric observation? And what is the department doing to ensure that these legally prescribed timeframes are adhered to? Lastly, Chair, my point of departure is on an overlooked issue in reintegration. What happened in cases where families refuse to receive state patients after discharge? And what social support system or alternative placement mechanism are in place to ensure that these individuals are not left in institutional or care indefinitely? Thank you, Chair.
Thank you so much, Honorable Sokopo. Honorable Taibush.
Thank you, Chair. The Department of Health, just want to thank you for the presentation. And I want to greet and welcome everybody from the Department of Health, JICS, and the Correctional Services Department. Honorable Chair, I've been mostly covered by Honorable Engelbrecht as well as Honorable Niaus and the other speakers, but there's still one or two things that I want to just get clarity on. The outstanding amount of 380 million that DOJ and Correctional Services owe the Department of Health. I need to know, and I want to know, is there any plan? What is the plan of getting that money recovered? Will it ever be recovered or not? Because I think the Department of is the Department of Health is just getting deeper and deeper into problems. And I want to almost ask that, is it not more humane for those waiting state patients to rather be transferred to mental facilities than keeping them in prison where they are exposed and where they are, where suicides and assaults and where they are a danger to other inmates? Isn't there something else that we can think of rather than to keep them in the prison facilities? Because my next question is, what kind of training, if any, does the Department of Correctional Services do for their staff members, their wardens, and stuff like that, to be able to work and handle state patients or people with mental disorders? Then, Chair, out of the 942 psychiatrists, 75% of that is about 230 of them, okay, that are, active in the Department of Health. My question is, what are we doing, if any? And where I'm sitting here, I can almost think of about 2 or 3 psychiatrists that I know that are unemployed, that don't have work, So, what are we doing? Is there a drive within the Department of Health to get more psychiatrists so that we can speed up this waiting process of getting people evaluated or state patients evaluated? What is the plan, is my question for that. Then, Chair, again, the waiting period is what is the possibility of getting, or maybe we should not even ask what is the possibility, but we should get the Department of Human Rights to do an audit or to do an investigation, because what's happening in the prisons and having these state patients, having them in our prisons is a complete violation, as the previous speaker says, of the human rights and the inhumane conditions that they are living in. So yes, it's unconstitutional, and the human rights are being violated. Chair, I think that's it for me. I've been covered. Thank you very much.
Thank you so much, Honorable Taibosh. Honorable Hendricks.
Thanks, Chair, and welcome back to South Africa. Honorable members, Department of Health, NC, JICS, be greeted, and everybody in the house. Chair, mine is, I went through and thanks to the department for the presentation, PowerPoint presentation. I went to the presentation when I received it. It says a state patient is an accused who has committed a serious crime. Now there's this trend that is going, and I want to understand from the Department of Health, if you picked it up, there's this trend that courts are now declaring individuals with minor crimes as state patients. Is there talks amongst the Department of Health and courts, and why this new trend? Okay, let me just, sorry. Okay, Commissioner, this goes to the Commissioner of Correctional Services. I saw in Drakenstein, I think it was a month back, you were commissioners from the SADC region, and this question comes on the back of a debate we had last week of overcrowding, because I take it if this issue of state patients are not remedied, it contributes, Commissioner, to the overcrowding of prisoners. So is there any talks that you had with those commissioners from SADC pertaining your illegal and legal immigrants in our DCS facilities? then to the department, what are the reasons for the delays by courts in granting discharges or reclassification of state prisons? Another one is the infrastructure of all these facilities that your Sterkfonteins, your Komanis, Elizabeth, and your Fort England. Why are they left to dilapidate? Why is these buildings not taken care of? Department, and it is said because we would have liked the Minister of Health and the Minister of Correctional to sit in this meeting, because I think with the meetings we had coming to this meeting, it spoke a lot, NC, about overcrowding in our prisons and the unhealthy situation. Mine is, if I zoom in and I look at the three departments, it doesn't seem as there's a working relationship, there's talks between the departments, because if I look at SEPS, I would say the problem starts when you apprehend these individuals. Is it now for serious or for minor crimes? I don't think SEPS has the capacity to evaluate or even see, is this a mental case or is it a normal human being? Because this person will be taken now from SEPS to court, be reminded to DCS, sit in DCS with a backlog of court cases we have. In that space, where is the Department of Health? From SEPS until DCS. I think that would also help a little bit in when courts are declaring, or I mean that advice amongst departments would be very helpful, and it will also help us with the overcrowding. And I think if we can get the number of all the foreign prisoners or state prisoners in our prison, it will also be helpful. For me, I feel the TCS is a convenient place for SEPS to go and dump these patients, because then it becomes a problem of DCS, and as you can see, the delays in these patients getting spaces at all these facilities is saying to me that the working relationship between SEPS, Department of Health, and DCS needs to be strengthened so we can all work towards fixing and making sure. I remember when I was still a paramedic, hospitals used to have these wards or cells where they would keep detainees awaiting. Can't we have these setups, because it's inhumane, as Honorable Carl has said, to keep a state patient, if you read and you understand the criminal procedure. First, the ones that we are keeping now are not even serious, are not even in for serious crimes. So why are we burdening? And mine is, it's a burden on the TCS having this patients in your facility. My last question will be to TCS, what dangers does these people pose in your facilities? With that, thanks, Chair.
Thank you so much, Honorable Hendricks. Honorable Klute.
Thank you, Honorable Chairperson. Firstly, allow me to greet the honorable members, Delegation of the Department of Correctional Services, Delegation of Health, and all protocol observed. Also allow me to thank the department for the submission. I will not repeat what other honorable members have said, but I'm going to ask 3 questions related to the presentation that was presented. Honorable Chair, there are 14 designated psychiatric health facilities nationally with uneven distribution and capacity pressures. What is the current bed capacity per facility, and how does this compare to the demand? Also, what is the department's medium to long-term plan to expand capacity to meet the growing need? My second question is, Honorable Chair, and some honorable members have touched on it. The department previously indicated that a facility in Mpumalanga was under development. What is the current status of the Mpumalanga psychiatric facility? What delays have been encountered? And when can the committee expect it to become operational? There are concerned that some patients may be staying longer than necessary due to administrative and systematic delays. What is the average length of stay for state patients in psychiatric facilities, and how is the department ensuring that patients who no longer require institutionalization are discharged and reintegrated appropriately? Honorable Chair, lastly is that where I come from in my region, I know a psychiatric patient is doing the normal things what the normal individual has to do. But whenever he do a wrong thing, he's classified as a psychiatric patient. Do we also have such patients in our facilities? Thank you.
Thank you so much, Honorable Klute, and members, for your questions and clarities. I think questions that have been posed by members were directed to both the Department of Correctional Services and the Department of Health. Therefore, I would expect that both departments to respond to the clarities and questions that were posed. We'll start with the Department of Health. The acting DDG will then lead with your team to respond. And then after the National Commissioner, you come in with your team as well.
Okay, thank you very much, Honourable Chair, and thanks, Honourable Members, for the questions. There are many, so I hope I don't miss too many, but let me try to respond to what I can, and then Dr. Shiba will help with some of the numbers and the technical details. I want to start off just generally saying, because the second set of questions was about us as healthcare professionals, we are incredibly worried, not just about mental health patients, but about all vulnerable patients. And that includes patients living with disabilities, children, etc., etc. There are many very vulnerable people who we look after in the health system, particularly in the public health system, because they don't have the means to purchase their healthcare services. So we have to look after them. So we are extremely worried, and I will say without any fear of doubt, the Minister, Motsoaledi, has been on us about mental health patients in particular, and it's been a particular drive of his for us to get the mental health care boards in place in all provinces, because they were not there before, and to make sure that we comply with our own mental health legislation. So I really do want to assure the committee that this is a very high priority in the Department of Health. It's not the only high priority, obviously. We have a lot of other things to concern ourselves with, but mental health has been a very particular thing that the Minister has been on us about. So I think in an ideal world, I would agree, and we as a department would agree, that once a person is declared a state patient, they shouldn't be in a correctional facility. But the fact of the matter is that neither department has the capacity to deal with all of them. So transferring a patient into a health facility where we don't have the kind of security, we don't have the kind of training to look after violent patients in particular, and to overcrowd that space might actually create a bigger problem than the problem we've got now. I'm not minimizing the problem at all, and I'm agreeing with all the comments that were made about the departments working together to try and solve the problems. It's not a competition. This is very much a we need to work together to solve the problem. And I will respond on where we see the low-hanging fruit and where we have very serious problems in trying to deal with it. We recognize, and working with the colleagues in Department of Correctional Services, and just from the normal reports in the media, we recognize the overcrowding in DCS facilities. But we must also recognize the overcrowding in health facilities. It's a massive problem for us. Our budgets have been reduced year on year for the past 12 years, and we are really in a lot of trouble. The population has grown and the budgets have decreased, not increased. So the calls that were made for a proper budget and a structured program, we would really appreciate that support from the honourable members of Parliament, remembering that it's actually it's Parliament who makes the budget, and without your support, we are not going to solve the problems that we are facing. We also recognize, of course, that there's not unlimited public budget, and that's why it's incumbent on us to save everywhere we possibly can and to do things as efficiently as we possibly can. We also do recognize, and unfortunately I have a very personal experience of a family member who died of suicide in a correctional facility, also post a violent while he was waiting assessment. So all I can say is I feel the pain. We understand. The misalignment of figures, we will have to, you have to look at actual names of patients or people before we will see what the problem is. But I suspect it's to do with cutoff dates. We even have that problem in our own facilities, where if the cutoff date changes by 1, it can affect the numbers by 20 or 30. So it's not unreasonable to suspect that the numbers will not be exactly the same, but that's not an excuse. We will have to go and harmonize at patient level to check why these numbers are different. So the challenge that was raised by some of the questions about the court sentencing and deciding that a patient is a state patient. Yes, we have seen a tendency. So we don't work in the criminal justice system, but we obviously observe and we know what is classified as a serious crime and what is classified as a less serious crime. And we are aware of the different categorizations. And we have seen a tendency that patients who are not accused of serious crimes are being declared as state patients. That's not to say that those patients will not benefit from being in a healthcare facility and looked after in a healthcare facility, but it does affect their classification and therefore the way that we deal with them within our constitutional democracy. So we can look at them I think it's important for us to look at these patients on an individual basis and for us to interact with the Department of Justice and Constitutional Development, which is where the judgment comes from, to see whether there's some guidance to the courts on maybe some of these patients were inappropriately classified as state patients. I don't want to say the numbers are huge, but it may be that then makes it more difficult for a patient who is definitely accused of a serious crime and who should be in a health facility as a state patient. So the question of Mpumalanga is a massive frustration for us. I've been in the health department one way or another now for 43 years. And we have been talking about some of these hospitals since pre-1994. The George Makari Hospital, which is the flagship hospital of what was Medunsa and now is Safato Makhato Hospital. The foundations for that hospital were dug in the previous dispensation. That hospital has still not been built. We are incredibly frustrated with that process. And it is complicated by a number of things. One is that infrastructure is not built by the Department of Health. It's built in conjunction with, and in some provinces, by the provincial departments, the provincial works departments, and they're getting part of their budgeting for infrastructure comes through the provincial equitable share, and only a small portion comes through the national conditional grant. So because of the pressures that individual provinces will have, and those that inherited homelands have had inordinate pressures on them for infrastructure, they have never caught up with their infrastructure demands. That's not to let them off the hook, and it's not to say it's acceptable. It's just to record that this is a problem that we have. So we have a more coordinated approach to it now, and we have had ongoing discussions with Treasury. The Minister of Health and the Minister of Finance have had numerous engagements over the last 2 years about these 11, it was 14, it's now 11 infrastructure projects, of which this is one of the frustrating projects that has just not happened. So these projects are big, so they are funded not out of the normal budget process, but out of what is called the BFI, which is a Treasury guided and managed fund. And so the infrastructure fund is now the source of this money. And all public buildings, new infrastructure buildings, and big builds on top of existing builds have to go through what's called the FIPDM process, and I'm sure you're familiar with this in building correctional facilities. So they get into a rank order within the Treasury budget cycle. One of the challenges we have is there's an expectation from Treasury that our facilities must generate revenue. Now I ask you, how does a mental health facility in the public sector generate revenue? It's not possible. So when we argue and we say that the socioeconomic impact assessment is that there's no return on investment, that's a cash return that we are talking about. But what is the return on investment for the people, for the public, for the patients? It's innumerable. You can't even measure it. But that's not how it's measured in the process of our motivations. We were even asked, can't we charge more for the parking? I mean, that's like a slap in the face to the health department. If you ask us, can't we charge more for parking to raise revenue from a public health facility? So I think, you know, in our defense and in our attempts to build these facilities and refurbish and expand the existing facilities, and you heard there's an attempt to expand one as well, it's not easy within the budget constraints on the country, but on the way that we have to account for what we are doing, particularly in this kind of environment where there's no chance of generating revenue whatsoever. So the exact status of this facility is that it is designed. We know exactly what's required. It's been designed for some time, and it is in the BFI. It will go into the BFI windows. There are 4 windows this year where we have to submit projects. And so they are sequenced, and it is one of the 11 projects in the 4 BFI windows to Treasury this year. The Minister of Health has written to the Minister of Finance to inform him of our intentions of which projects will come in which windows. The mental health facility in Mpumalanga is not in the first 2, purely because there's still issues around the actual physical site of where the construction will take place. The state has to own the land, and there are always issues around that with municipalities and so forth. But it is designed. So it's true that accused wait for a very long period of time for their assessments. It's a massive frustration. If you look at the workload on the psychiatrists, having 250 or 260 psychiatrists, and I'm fascinated to hear it's possible that there can be psychiatrists unemployed, we can employ them tomorrow, because we have a conditional grant that is specifically for mental health care, recruitment of mental health care health professionals. And our biggest problem is finding people to do that work. You may find that they are well available in Cape Town or in Joburg or Pretoria, but we might need them somewhere else in the Eastern Cape, and then they're not in the Eastern Cape, and the logistics of getting them to the facilities is a problem. But for us to employ people, certainly those who are in private sector on contract, we have a standing program. It's a sub-allocation within one of the conditional grants for healthcare practitioners, where we can certainly employ additional psychiatrists. The challenge is that the private psychiatrists are pretty busy, and it's much easier for them to work in the private sector. So there's not a serious motivation, particularly at the rates that the public sector pays for medical specialists. There's no incentive for a psychiatrist, and even to get them onto our committees and the evaluation panels, it's not every psychiatrist who's willing to work there. So we recognize that problem. And it's not going to be resolved in a short space of time, because the training period for medical specialists is very long, as you're aware. And even when they come out, they might not go into the public service. We are well aware of the litigation threats, and whether it's on DCS or on the health department, it makes no difference. It's a litigation threat that is probably very justified. And we have been through Life Isidimeni, and we have been through other mental health complaints. We've been adjudicated by the Health Ombud. You would have seen last week, Monday, there was the Health Ombud was reporting on some cases that have been investigated. We've been to the Human Rights Commission to explain. So, yeah, we are well aware, and it doesn't please us at all that we are not able to respond as fast as we would like to. On the question of not being paid, as you know, that's been long outstanding since 2023. Departments don't generally take legal action against one another. We continue to negotiate and discuss how we are going to get transfers. But we also do recognize that all departments have got their own financial challenges. So putting pressure is difficult. I'll give you an example in the Eastern Cape, because there was a question about the capacity of those facilities and why we are not able to recruit more. The Eastern Cape Department of Health, remember that the Health Department doesn't have a budget. It's got 10 budgets. One is the National Department, which is about 90% of the National Department's budget is conditional grants, which are transferred for specific, under specific conditions to provinces. The bulk of the health expenditure, by far the majority, is in the provincial equitable share, comes from the provincial equitable shares and is in their budgets. The Eastern Cape Department of Health has accruals of 21% of their budget. That means tomorrow, is it tomorrow, day after tomorrow, on the 1st of April, the Eastern Cape Department of Health will have already spent 1/5 of their budget on day one, just on what they owe on previous years. And those accruals go back as far as 12 years. So unless there is a plan, a collective plan, and again, this is something that we've discussed with the Appropriations Committee, we've discussed it in the Health Committee, and I'm raising it again here. Unless we collectively address some of these historical backlogs, and that's a province that inherited two very large Bantustans or homelands. They've never really got on top of the situation, and they went through a period of quite serious corruption and plundering. And what happens is that once you are on a downward spiral and your budget is being consumed by human resources, by paying for doctors and nurses, then you've got less for medicines, you've got less for your construction and maintenance, and you start to make mistakes. Doctors and nurses get burnt out, they leave, and this spiral gets worse and worse, and we end up with medical legal cases. So you're aware of the medical legal cases. We have many, and it's a massive problem. Some of that is fraudulent, but quite a lot of it is justified medical legal claims that we just can't get on top of because of the accruals that we're dealing with within the system. So we care passionately. We're about 700 employees in the National Department of Health, and there are about 350,000 employees in the provincial departments of health. We're about 700 people. And we try very hard to make sure that the policies and the budgets match one another. There was a question asked, one of the honourable members asked about the operational plans, the APPs and targets, and how do we match them. We do to the best of our ability, but remembering that we are trying to coordinate competing demands that each province is dealing with, and they differ. HIV here, TB there, and so on. And here in the Western Cape, the violence that goes on here and the trauma is more than you would experience in Limpopo, for instance. So each province is trying to deal with their own set of demands within a common set of rules, if you like. So I'm not trying to diminish it. It's really just by way of explanation of where we find ourselves. But I want to keep coming back to the fact that this minister has been adamant repeatedly with us that we must protect all vulnerable patients, and in particular mental health patients. So there was a question raised about the number of patients that have been taken out of correctional facilities into health facilities. It was on one of the slides. It's about 10% per annum of the total number. So that was an 11-month period we were reporting on in the slide. There were 390 something, I'm trying to find the figure, 339 patients in 11 months that moved. So that's the sort of size of the turnover in a 12-month period. So it does mean that patients are exiting the system. Hopefully, majority of them can be accommodated back into their families and the community, but that's not always the case, as you're aware. Yeah, I will certainly convey to both the Minister and the Deputy Minister the displeasure of the House, of the committee, of them not being here. But as we explained, there are legitimate reasons why they're not here. And I will also convey the request that we have an ongoing quarterly feedback and that we have some structured engagement on the actions that are being taken and the progress that's been made towards those actions. We will certainly convey that to both the Minister and the Deputy Minister. Yeah, so one of the questions that was raised is on our minds at the moment, and that is, how are there, other than the 14 facilities which are designated state patients facilities, are there other facilities, particularly in Mpumalanga, that we can use temporarily? Well, potentially yes, but it still requires construction and it still requires staffing. And the construction is in a way the easier part. The staffing is the problem. So even if we were to isolate a portion of Witbank Hospital, for instance, and make that a temporary SP facility, we still have to staff it appropriately. You can't have a state patient facility with no psychiatrist in it, or with one psychiatrist who's not looking after them. So that has to be part of the Mpumalanga budget, and again, it's got to compete with the existing provisions of what they are doing. And not to say it can't happen, because it is very much part of our current thinking and discussions with the Mpumalanga province. I think we also take the point that people are tired of PowerPoint presentations and we need to come with more concrete steps. We will convey that to everybody in the department. I think many of us also share the sentiment of being PowerPointed out. Yeah, I think some of the questions were, in a way, I've covered them with answers to others, so I'm not going to try and respond to every single one. There's a lot of questions about Mpumalanga, and I think you've by now realized that we are quite unhappy ourselves about the inability to deal with the situation in Mpumalanga. Yeah, there was an interesting comment made about the 9.7% increase in state prisoners patients in 5 years. So that's higher than the increase in the population. We've looked at the areas, and that was partly what was covered in the slides. So there are a number of reasons for it. One is the increased use of drugs. It definitely has increased the number of violent crimes, and we are seeing it in the patients that end up in our facilities. The second one is the question that we raised of the potential that some patients may not need to be state prison patients because maybe they could have been classified or they didn't commit serious crimes. They were lower than serious crimes, but I mean, that might not be a large number. And then the population is increasing as well. So that is why we are seeing an increase, and therefore an increase in the waiting time. So the question of ring-fence budgets has been debated repeatedly in the health sector. We don't ring-fence budgets. Except for historically, we had the HIV budgets were ring-fenced, and that was largely because they were donor-funded. So we lost 8 billion off our budget on the 20th of January last year, overnight, when the United States changed their development funding, and we were receiving around 8 billion through the United States PEPFAR program, through two programs, the USAID and the CDC program. Some of that money was restored temporarily, but comes to an end today. So we now have no additional funding. We have lost 8 billion off the health sector. We went to Treasury for an emergency appropriation, and you kindly, as Parliament, supported that. But it was 750 million rand, Section 16, which the Minister of Finance tabled as an emergency funding. 500 and, I can't remember the exact figure, I think it was around 540 million of that went to the provinces to assist them with the transition out of losing pretty much 8 billion. We still get an allocation for TB, HIV, and malaria from the Global Fund. But we've just received the new allocation for the new grant cycle, and it is substantially less than it was before, so that's another loss to the health system. And it will terminate in 2031. So I'm afraid the pressure on the public health system at the moment is higher than it's ever been before. And we're finding it difficult to recruit permanent staff, clinical staff, and so on, because there's a very sizable and powerful private sector, as you're all aware, that we compete with for spaces and to employ people. That's not to say we are not addressing the challenges that are raised in this particular meeting. I think you need to be convinced, I hope you've been convinced that we do take it very seriously, but we also have to be very realistic. You can't just conjure up the professional staff and the facilities. These are very specialized facilities, and while we recognize our colleagues in DCS have challenges, the challenges in the health system are not insignificant. I will leave the questions on the foreign nationals and on screening in correctional facilities to my colleague. I think the Honourable Niehaus mentioned that the meeting or this committee would request that this be declared a national emergency and that we get a plan in place to transfer every state president's patient out of DCS within 90 days. We would love that. I think you mentioned a figure of 1 billion. I mean, that would be very exciting if it were possible to get that kind of funding, getting the departments that are involved together to panel beat a plan to make emergency preparations would certainly be something we would support. We have no problem working with the colleagues in the other departments at all. But you can understand when we're all under pressure, we push back on things that are going to compromise us and potentially make it even worse for the patients we're trying to look after. But that would be wonderful if somebody gave us money to fix the problems that we're dealing with.
National Commissioner, you want to give them the money?
Thanks.
Thank you, Honourable Chairperson. We've already written to the Department of Health, giving them the bill, not the money.
You can proceed, Acting DG.
Thank you very much. It's so fun to have some humor in a very serious subject like this. Yeah, so in terms of the legal framework within which we operate, there's been an ongoing review of all the health legislation through I think it's, well, certainly, I've been back in the department now just on 5 years, and it was going long before I came, long before COVID. So I don't know when that's going to come to an end, but there is a review of all health legislation, and there is a review, we are under pressure to look at some aspects of the Mental Health Care Act as well. So I suspect that, I mean, we're not legal people, we've got to respond to that law, so we work together with the Law Reform Commission, and they have given some guidance. It's very substantial documents, and I'm not sure things are going to change in a very short space of time. But we look forward to the time where there are some changes, and maybe we should be looking at those sections of the Law Reform Commission reports that impact directly on mental health to see if they can be accelerated. Although they've been looking at it more as a package and not as piecemeal changes to the laws. I think I'm almost done. Mpumalanga. The question of the observation backlog, it's huge. The most recent figure is 2,783 patients are waiting for observation, and the time period for some of that waiting is obviously very long. If you recall, of course, because these patients are then in the facility for 30 days, sometimes extended for another 30 days, then that's the reason for those observation backlogs. I'll let Dr. Sheba respond, but there are patients whose families refuse to take them back, even when they have been rehabilitated out of the healthcare system. So they've been through correctional services, they've been in the health facilities. And the trick is really to make sure that right from the beginning the families are involved. But you can imagine, if you have been a parent or a grandparent and assaulted by a grandchild or a child, viciously assaulted, you're not going to be in a hurry to have this person back in your house. You're going to be afraid of them, even if the health facilities and the health services say that this person is rehabilitated. So having that ongoing relationship, that's why the facilities have to be close to the community, so that the families can have their patients back at home for a week, and then for a bit longer and a bit longer, so that they acclimatize and familiarize themselves back into the community. But I'll leave that to Dr. Sheba to talk about first-hand experience. Yes, it is more humane, Honorable Taibosh asked, it is more humane to have the patients in a health facility when they need health help, definitely, there's no question. But if they are also going to be unsafe there, because there's nobody actually looking after them, because there aren't professionals, and they don't have the same kind of security that they would have in a correctional facility, we're not necessarily making things better for them. You just, in a way, you're transferring the violence into an environment where you're not necessarily better equipped to deal with it. I mean, you don't necessarily walk around injecting people to keep them quiet when they get violent. That's not always the most appropriate way to deal with violent episodes. Yeah, I think I've covered the questions of infrastructure quite well. So I don't think it would be true to say there's no working relationship between departments. There is. I'm sure we could all do it a lot better, and maybe this forum is encouraging us to do so better. But there is a relationship between departments, and there's an ongoing discussion about individual patients and services. So I think I've noted it specifically and made a particular note here that we should do better and work harder. And I know that the Minister did have a discussion with the Minister of Correctional Services when he apologized that he wouldn't be able to come to this meeting. And then he heard that the Minister of Correctional Services also wouldn't be able to attend this meeting. So even at ministerial level, we are aware that they are talking to one another, and our officials definitely do. So I'm not sure if I've missed anything in particular that Dr. Sheba wants to catch up with. Thank you, Honourable Chair.
Thank you, Chair. Thank you, Prof. Crisp. I just wanted to add, in terms of the numbers of backlogs that Prof has indicated, just also to indicate that in the midst of the challenges of not being paid, since we said the last time was in 2023, within the resources of the Department of Health, in 2024-25, we conducted 2,795 or forensic mental observations within the by the department, and for the 11 months from January up to now, we have already conducted 2,482, and this is taking a lot from our resources, but with an understanding that if we stop doing it, the people who are going to feel the pinch are our people themselves. It is not going to be justice and constitutional development or treasury or whoever. So the little bit that we have, we continue whilst we are negotiating. And over and above these, there are also other things that we do for the Department of Justice, that is the criminal capacity assessments in terms of the Child Justice Act. And it is part of the bills that we are not getting. So I wanted to highlight that we do, and we are getting a lot of referrals. For an example, in 24-25, there is an increase of people who are being referred for forensic observations, and about 10% of those end up being really found to be either criminally not responsible or not fit to stand trial, meaning the load of the forensic observations that we do, people are found to be, but we have done the work. For an example, in 24-25, we got the referrals, the number of referrals we got just for that year was 3,183. And this year, we already have received the court referrals 3,414. It's the work that we keep on doing in the midst of everything, because our understanding is that we can't just drop it. The people are the people who are going to suffer, and it will be a justice denied even for the 10% of our patients that would be waiting as such. With regards to the number of beds, we do have the figures per facility, but nationally, the commissioned beds for state patients is 2,208 in the whole country. However, the usable are lesser because of the disrepair, but also in other facilities, they have gone beyond the capacity that they were commissioned for. For an example, recently in Fort England, we found a way of squeezing in additional 16 beds to make more space in terms of that. So the usable beds are 2,136, whilst the commissioned are 2,208 in terms of the beds that we have available. Something else that I needed to respond to, I think in terms of the discrepancy in the numbers, I support what Prof has said, but also we frequently from time to time with my colleagues do this reconciliation. Unfortunately, by the time theirs came, we had already calculated ours, because immediately a state patient is declared in the court, the responsible prosecutor and as well as the clerk of the court inform the facility where the observation was conducted, because in most cases that is where the patient, so the bed is already booked. So that is the numbers that we get. But then Correctional Services may be a bit behind us in terms of that. Sometimes when we have this number and we check the reconciliation, we find that they have not yet, processed, because they are still waiting for court papers, orders and all, and they can only process once they have received. So whilst the figures are the same, the timing may be a bit different, but we from time to time reconcile the numbers in terms of making sure that they are. In terms of the foreign nationals, it's a statistics that we would have to ask for from the facilities. We have not normally been collecting in terms of how many of those are foreign nationals. We did it about 9 months ago, but I wouldn't talk about those figures because they wouldn't be the true reflection. We'll have to go back and do a new one in terms of what, but from the figures that we got 9 months ago, those that are declared state patient, it was very few, I can't recall, but it was a number that was not even above 10 at the time we got at 9 months ago, meaning those who are state patients and foreign. But then we are talking about those that are with us in the Department of Health. I'm sure those that are in the Correctional Services, colleagues may be having that information. With regards to the systems that are used in our facilities to ensure safety of the environment. State patients are sometimes, the level of risk that they carry is high. Therefore, even the facilities where we keep them and the staff that is supposed to look after them is specifically, trained to make sure that they are able to handle those situations. We do have the norms for facilities, how to build a psychiatric facility, whether it's an observation or whether it's we differentiate between what we call a medium to high secure need and those with low secure need, and even the infrastructure we built differently because those with low need, we are preparing them to exit, so we relax and make it as homely as possible as part of the rehabilitation. We do have guidelines that we use as we build. However, the current state facilities were built many years ago, some are 100 years old, so it was before the guidelines. So this is what we sit with, but for facilities like Bupilong that we are building now, we have guidelines that we make sure that the facilities are okay. And then in terms of what we do, whilst the patients are still in correctional services, we have been in constant contact with our provinces to say they must remember that these are our patients. They can be in correctional services, but we take responsibility. They are our patient. As a result, provinces, we know it has taken off very nicely in Free State, Gauteng and Mpumalanga, where our teams visit correctional services and consult these patients, prescribe medications. And I know in Vescopis, the arrangement with the facilities in Gauteng, they are brought in to the outpatients. If there is a need for the visit there, we do that in as much as we can to try and make sure that we don't just say they are sitting there and there is nothing. And what we have done recently, we have written a circular to provinces to make sure that they, all of them, because all of them, they are doing it, but not as good as Free State, Gauteng and Mpumalanga, where it has matured. So we have been urging the other provinces, with the exception of Western Cape and Northwest and Limpopo, because they do not have this problem as much. But in other provinces, we have urged them by the circular to ensure that they make it, and even the medication must come from us because they are our patient. We can't burden our colleagues in social development, in correctional services about that. The issue of the bed capacity, I have covered it. The experience about ensuring about the families not, or about the crimes, not families not wanting. It's a serious problem, but I've recently had meetings with a meeting specifically with my counterparts in provinces to say, we need to make sure that we enhance the understanding that people, in terms of the treatment in mental health, you don't treat a patient away from the family. So as much as possible, we push that these people are nearer to their families so that we work in terms of the leave of absences. They have a weekend home, come back as a trial, because that is a part of how we do in terms of their rehabilitation and making sure that we deal with them correctly. Lastly, Chair, in terms of the figures, there was a figure, how many, the state patients that died in prison. No, I think that figure, maybe our colleagues in correctional services can assist. We do keep a figure if it happens that a state patient die in our facility. We have those figures. These are part of the figures that we'll have to share from time to time. As I've indicated, we take full responsibility that they are our patient, and if something happened, we should be having this data, including the data of those who died. So it's one of the things that we'll have to take on now as we share the figures that we do. We need to make sure that we also include those who died whilst waiting in prison. Thank you.
So you're saying to us you don't have that figure? You don't know any of the state patients that are incarcerated in correctional facilities that might have died?
That's what I'm saying, Honorable Chair, that and that has been a gap because we only know the numbers for those that are with us. We need to correct that because it is a very, very wrong thing that we do not have those figures. From tomorrow, I promise that is one of the things I'll come out here and look at my colleagues and we update our statistics to add a column that says died in the health facility or died in the correctional services facility. We will do that.
I think the department will be able to assist us if we have any in correctional facilities, but also there's gauges to a point that there is no communication between the two departments, because if there was, you should be sitting with that information. Because of, like you have indicated when you were responding, these are your state patients. Even though they are incarcerated in correctional facilities, you take full responsibility of them. Therefore, by doing that, it means that you should be kept abreast and you should know anything or everything that happens to them, whether in correctional facilities. Then that ponders a question: do you really take care of them if you will not be aware if one would have succumbed or died in a correctional facility? National Commissioner?
Thank you, Honorable Chairperson and honorable members for the questions. Honorable Chairperson, I want to request that we allow the Chief Deputy Commissioners, both remand detention and rehabilitation, to start first. If there's a question that they have not answered, I will then come in at the end. Through you, Honorable Chairperson.
I think it's CDC Ramulifo, or is it Molepo? Both, okay. Ms. Molepo, you'll start.
Thank you very much, National Commissioner, and greetings to yourself, Chairperson, honorable members, Inspecting Judge, Acting DG, and all members. Chairperson, I will start with the very same comment that you have just made in terms of the number of state patients who died in our facilities. I need to indicate that currently we do not have any state patients who died in our correctional facilities, because like you have indicated, you have correctly put it, we should have informed the Department of Health, because we are working with them very closely in terms of the state patients. So on the question regarding the interventions of transfers of state patients, I think the acting DG has correctly put it in terms of our engagements. As the Department of Correctional Services, we have been engaging with the Department of Health in terms of the state patients within our facilities. We had quite a number of meetings in 2025. On the 4th of November 2025, we had a meeting with the Eastern Cape. We also had a meeting on the 5th of November with Free State and Northern Cape. And for Mpumalanga and Limpopo, we had a meeting with the Department of Health on the 7th of November. And Gauteng, we had a meeting on the 9th of December. And KZN, we had a meeting on the 12th of February 2026. So this is just to show that as the department and also Department of Health, we are working very closely. There's also a Department of Health Ministerial Advisory Committee on mental health, which visited the Department of Correctional Services, and they have requested nominations from us. So as the department, we had represented the department during that Ministerial Advisory Committee on mental health, and they have visited East London management area in the Eastern Cape. That was on the 14th of November. So from our healthcare services, we had a representative who represented the department during that Health Ministerial Advisory Committee. They've also visited Grootvlei management area in the Free State and Northern Cape on the 13th of March, and we participated in that Ministerial Advisory Committee. The other one is that the Department of Health is currently reviewing the Mental Health Care Act, and they have requested our inputs, which we have provided them our comprehensive inputs with regard to the Mental Health Care Act, and we hope that our inputs and comments will be taken into consideration when they finalize the review on Mental Health Care Act. So whilst we are still on the transfer, I just want to indicate, I think there was one question in terms of the number of transfers, to say since April 2025, we had transferred 159 state patients to the Department of Health. So we do have those numbers per region. For Eastern Cape, we have transferred 42, and Free State Northern Cape, we transferred 65, and Gauteng, we have transferred 10, and KZN, we transferred 28, and LMN, we transferred 14, and Western Cape, we did not have any state patients. So that is with regard to the transfer of state patients, just to show that we are working very closely with the Department of Health. Coming to the issue of training with regard to our healthcare officials, we do provide training. We had a virtual training on the approved mental health care policy and procedures that was conducted on the 25th of November 2025, and it was conducted to all the regions, and that included the healthcare professionals and also heads of correctional centers. We have recently signed an MOU with Johnson & Johnson, and they are also going to provide training to our healthcare professionals in June this year, 2026. And with regard to the questions on interventions for mental health care users, what we are doing from the department is that from admission, we do provide screening. We also refer the mental health care users, if there are any psychosocial support needed, we transfer them to our social workers and also our psychologists, and we also do provide treatment to some of the patients in line with the standard treatment guidelines for primary health care. So with regard to secondary health care, then we refer to the Department of Health. And in addition to strengthening the treatment of our state patients, we have appointed 19 psychiatrists on contract. So they are currently assisting us with regard to the mental health care users. Then the other question is with regard to foreign nationals, state patients. Currently we do not have any foreign nationals, state patients. And regarding with regard to mental health care users, in terms of statistics, we currently have 6,290. I think I forgot to indicate the statistics. The other issue is in terms of cost with regard to our state patients, is that we are currently spending 462 costs per capita, but what we did is that we have included the 50% risk cost. As indicated earlier, that we had a meeting with the National Treasury, so this is the figures that we have submitted to them to say, per state patient, we are spending around 693 per day, which amounts to around 20,000 per patient per month. Yes, per patient per month. And for 407 state patients, then we are spending at around 8 million per month. National Commissioner, thanks very much, Chair. I think that is the figures from our side.
Thank you so much, CDC Molepo. Mr. Ramulifu.
Good morning, Honorable Chairperson, honorable members of the Portfolio Committee, National Commissioner, and Acting DG and JICS. I'll just want to also contribute in terms of answering in terms of the following questions. It's on the part of the strategical level, the intervention led by the National Commissioner. I will start by the letter that was drafted to the Acting DG already in terms of the integrated cluster action plan for 100 days, which our National Commissioner already have indicated to the various DG at a strategic level. Again, we also contributed to the Criminal Procedure Act on the revising to give more delegation and funding to a budget where if we are finding ourselves at a national level and provinces that we are needing of more psychiatric, we need to be funded directly from the Act, also from the policy. And that inputs led by our National Commissioner, which we prepared, we was also as part of the intervention. On the national level, again, various engagement jointly with JICS from 2007. There was a question about October. We started in 2004 together with JICS, visited Vetcopies, visited Starfontein, where an 18 Ward 18, which actually has a backlog of 35 inmates from Mpumalanga, are having 6 months, was the one project led by our National Commissioner and the former JICS, which we continue together at the national level, intervening and unblocking the transfers and also the services of treatment of the inmates, the state patients. Again, also at a national level, the presentation made by the National Commissioner at the NEC, which also include the flagging the state patients at that level of the judiciary, was something that also currently starting to yield a bit of results on redirecting the minor cases. I just wanted to add on the intervention, again, the issue of the tariffs charging the Department of Health at a national level. That is what is currently ongoing. We want to reflect that because it's part of the motivation for the overcrowding and the reduction and the tariff charge against the Department of Health, which is the intervention by the National Commissioner. I will also want to just confirm that our statistics are directed by the court admission in terms of the court order J105, MC20, MC22, MC23, that it's utilized in our admission to record the admission in our facilities. However, at an operational level, as my CDC colleague has mentioned, the engagement with the provinces, which we've been requesting through our National Commissioner, that the application of the intervention mechanism, which is utilized in Free State, Northern Cape, it needs to cut across on getting all the state patients who are fit, being treated, to able to go to court if it can be utilized. So our National Commissioner, together with the Regional Commissioner of Free State and Northern Cape, has been cutting across to request that principles of outpatient 1 hour visit and treatment sessions continue across the DCS, which we still have a bit of that challenge. I will also want to share the following, that in the issue of the exact figure, we are also participating at the DEFCON, which my colleague Shivu there, she always gets the statistics on a monthly basis on the DEFCON. My National Commissioner sits at a JCPS cluster. He is tabling that on every JCPS cluster because I prepared those statistics. And at that level, every cluster meeting, the state patient it's on record being said. So our statistics, it's very verified because it goes with the order of a court. We're not utilizing any additions and so on. I won't go much because my colleague has already covered most of the aspect. Just on the policy side, I just wanted to mention that our National Commissioner, again, leading the policy part of the review on the policies that we currently have, especially the protocol on the state patient, so that it assists the correctional service, again, while if we are keeping them, as you have seen, the cost that is actually taken from our own budget to continue assisting in terms of their health and the human dignity. We continue to give them human dignity and support. If you take note that most of them that are brought in our facilities are very high risk inmates, state patients, compared to the ones that are outside treated in various state patients hospitals. You will find that we are doing fairly well as a department. We give them the best care and the best support until when they are released to go for an observation. And there are no incidents that you can record and up to this far in terms of the support that we are rendering and the human dignity and respect that we continue to adhere to in terms of the Nelson Mandela rules. I wish to submit National Commissioner and the Chairperson of the Portfolio Committee. Thank you.
Thank you so much, CDC Ramulifu. Can I request you and Mrs. Molepo to switch off your mics? Thank you so much. National Commissioner?
Thank you, Honorable Chairperson. The only question that I have identified having not been answered is the question with regards to the type of dangers that the system gets exposed to because of mental health inmates or state patients. I think the colleagues from the Department of Health did indicate that there are mental health inmates and state patients that are that needs more attention than others. Now, it means upon observation by our healthcare professionals, we now then need to determine where do you house, where do you accommodate this type of an inmate. In some instances, we isolate them, meaning that we accommodate them in single cells. Now, once an inmate is accommodated in a single cell, that inmate needs to be checked upon on an hourly basis. So it puts a strain on the system. And then others, we house them in our clinics or hospitals, but now there are other inmates in the same setting because those settings are communal settings, in as much as you also have single cells. Others are actually with other inmates in normal communal cells. So the risk varies, and we have to always make it a point that we provide the special care that the CDCs were talking about, but it means that this is an inmate that needs to be observed as an individual and attended to as an individual on a daily basis, 24 hours, 7 days a week. There was another question asked about the type of training. Yes, health professionals, but the members, the security, the members that are in charge of security get briefed and debriefed on, the observations that the healthcare professionals would have made. It may sound as if it is an environment that is manageable. It is not. For us, we would not want to have state patients or mental health inmates in a correctional setting. Yes, we have security systems that can deal with that. But the nature of a correctional system does not allow us to have that type of an inmate. And I don't want to repeat what the CDCs mentioned in terms of interventions at the cluster level. In terms of legislation, which is one of the things that whilst one was sitting here, I was thinking of. When we are to make contributions to the amendment of the Criminal Procedure Act, also the Correctional Services Act. I see a clash there between the departments, because who would want to secure provisions that we are very grateful to the support that we receive from JICS, the inspecting judge, the CEO, and the colleagues from JICS in that regard. Because who would want to secure provisions that do not allow the courts to send this type of individuals to correctional services? And if we get that provisions, it means it becomes more of a problem for the Department of Health. So we are having that conundrum that when we now have to finalize amendment of legislation, we would be sending the problem where we think it should reside. The Department of Health will be saying no, but actually our view is that we must look at this differently. Yeah, let me stop there, Honorable Chairperson.
Thank you so much, National Commissioner. I had, Acting DG, I had indicated that there are a number of letters that JICS would have written to the Department of Health, the National Department of Health, with regards to matters of the state patients, and those letters dated from 2022. I had said that when you do a presentation, kindly highlight what has been your response to those letters. And I haven't had anything from your side. So I would like you to come in and take us through if you had any recollection of those letters, and if there's something that you have done as the department with the concerns that the former inspecting judge would have raised with regards to state patients.
Yeah, thanks very much, Madam Chair. So I've been in this post now just over 2 weeks, so I won't have first-hand knowledge, but from being in the EXCO, I'm aware that we do respond to those letters, but in terms of the details, I'm going to have to ask Dr. Shiba, because she would have been dealing more directly with it. Thanks.
Thank you very much, Chair. Yes, we did receive the correspondences from JICS. They found us already pushing this, addressing this issue, but it gave us even more of the, the zeal to go on. We did respond, or Minister at the time did respond and gave the inspecting judge the summary of the work that was being done. What came up just after that as part of the trying to do as much as what we can from our side at the National Department of Health. In the Eastern Cape, we took it upon ourselves, and that 16-bed ward at Fort England, came up after that, trying to juggle and push the province. And also we entered the fray and were highly involved in making sure that Komani, which was admitting state patients and we were struggling with a psychiatrist, we took it upon ourselves to work with the province in headhunting, and then we were able to, get a psychiatrist, which is now a bit trying to ease. And the work of ensuring outreach by teams to correctional services took even a more dedicated turn after that, in such a way that, as my colleagues from DCS are indicating, that it is increasing so that we are able to collaborate even more. These are just part of the examples, or maybe another example is that Etumzimkulu, the construction at that time, was looking at coming up with a facility for both observations and state patients. But looking at the pressures, and then we have decided to drop the observations and use the space, even that one that was for observations, to increase the space of the state patients in that ward that is being built. These are part of the the work that we are doing. And there is some of the things through the collaboration with our colleagues in Correctional Services. So in a nutshell, the response, Minister did send a response with a summary, and there is a number of, increased impetus that happened after that, not that it found us sleeping, but it actually also made us to push even more our provinces, as Prof has indicated. Unfortunately, the way we work, we have to push provinces to be able to advocate for those things. Where we can, then we take it upon ourselves, like the headhunting that I say we assisted Eastern Cape with. Thank you.
Thank you so much. Inspecting Judge, do you have anything that you'd wish to respond to or to add to from your side? It will be injustice not to have Jakes to speak on this matter when you have been amongst those who are pushing the issue of state patients.
Thank you, Madam Chair. We do actually have a formal presentation, which we could take you through, the slide presentation, but I can also simply take
No presentation, Inspecting Judge. Just any addition that you want to put on,
Yes.
and yes.
All right.
Thank you.
Then I'll do that. If I can deal with the last issue which came up first, there has been correspondence between JICS and the Department of Health, the Minister of Health, in fact. And if you look at this bundle of correspondence, which I think is before the committee, quite a lot of it dealt with repairs to a ward at Sterkfontein Hospital, which was damaged, and also another facility where there was damage. We got a report, I think, in March last year, and we followed up in November last year and asked for feedback, further feedback. We haven't had a substantive reply to that, which we find a little disturbing. So perhaps the department can look into that again and give us a substantive reply. On our evaluation of the figures, the problem seems to lie principally in two areas, and that is the Eastern Cape and KwaZulu-Natal. On the figures that I have, and I've got no doubt that they're very similar, they're based on the department, on DCS's figures. If I just give me a moment to find those in my notes. Of the 407 state patients, the Eastern Cape, this is at, I think, the end of February, is responsible for 186 of those figures, and KwaZulu-Natal is responsible for 83. That together comes to 269, which is really the bulk of this backlog of 407, 409 or 437, according to the Department of Health's figures, state patients who are languishing in DCS facilities. So I was hoping to hear that there would be more concrete plans as to how to deal with the backlogs in those areas. It's pleasing to hear that there is some progress, however slow, in relation to establishing a mental health facility in Mpumalanga. But it seems to me the two areas which require urgent attention is firstly the Eastern Cape, by far, and also KwaZulu-Natal. So I was interested and find myself in support of the proposals made by a number of honourable members, namely that funds should be ring-fenced for infrastructure development and staffing in those areas. And there must be a way of doing that. I hear Dr. Crisp's explanation of the limited powers which the Department of Health has and budgetary powers, but somehow there must be a way of encouraging the Eastern Cape and Natal to improve their facilities and then thereby knock out most of this backlog. Then I want to respond at a personal observation level to hear that, because I'm hearing that the health staff in prisons actually do, in correctional services, do receive training, and that there is backup support for these state patients from the Department of Health. That hasn't been my personal observation. We went on visits to KwaZulu-Natal prisons about a month ago, and I specifically asked about that, and the staff, the health staff that we spoke to said they were untrained in dealing with mental health patients. I also specifically asked, what backup do you get from the Department of Health? This was in Pietermaritzburg prison. And the sister in charge there said that in all the time that she'd been there, which had been several years, she had a visit from the Department of Health psychiatrist on one occasion for one problem, and nothing else beyond that. So the point I wanted to make also earlier was that we talk about this problem as there's a lack of beds, just a lack of beds. But it's much more, as far as I can see, from my perspective, than a lack of beds. Once the state patient is in the correctional facilities, I don't see that there's a full panoply of services which is offered by the Department of Health. It seems to me that those state patients must then rely on DCS facilities, be it psychiatrists, psychologists. And if you ask the questions, those facilities are very, very limited, as they are in the various establishments. One psychologist, sometimes a rotational psychiatrist's services, something like that. So that seems to me that they will be fully occupied dealing with ordinary inmates and don't have the spare capacity to deal with state patients. I'd like to quote to you also, if I may, from a draft report on the Pietermaritzburg, the visit we paid to the Pietermaritzburg medium facility. This report will be issued shortly when it's been finalized, but I think the draft report will shed some light. A significant concern relates to the accommodation of state patients. As previously mentioned, 21 state patients are currently being housed at Medium A, with the longest standing patient having been detained there since 2020. This is deeply troubling, given that the placement of state patients in correctional centres is intended to be a temporary measure. According to the nurse in charge, the correctional centre relies on its own budget, resources, and mental health care professionals to manage the needs of state patients, with the Department of Health effectively relinquishing all responsibility over them. The nurse recalled that, as I've mentioned, during her tenure, the Department of Health had arranged for a psychiatrist to attend to a patient on only a single occasion. This is concerning. Although state patients may be placed in correctional facilities due to bed shortages at psychiatric institutions, this does not absolve the Department of Health of its legal responsibility to care for, treat, and provide rehabilitation services to state patients. I can also recall that we saw those patients. There was a cell, and there were in that cell that we were shown, there were 3 or 4 state patients, and they were lying there on mattresses. They didn't even have a bed, and the rationale was that they might fall off the bed in the middle of the night because of their illnesses, or if they have a fit or something like that. But it struck me as quite a dismal picture, I must say. So our recommendations echo those of which have been aired by some of the honourable members, and that is that this problem needs to be addressed as a matter of some urgency, and I favour, as the members have expressed, that we have some kind of ongoing process of checking and overseeing what the targets of the Department of Health are, or and how they are meeting these. Because on our analysis of the state patient incarceration trends, 2 years ago there was a total of 204 state patients. This year it's 407. So that's a doubling in 2 years. If you take it back further, 6 years ago, there were 117 state patients, and now we're dealing with 407. So this problem, seems to me, is not getting better. The trend is going in the opposite direction, and that is why I think I would like to commend this committee for raising this matter, because I think it is very, very important and something which must be dealt with a measure of urgency. And we would like to see this as a recurring phenomenon so that targets can be set and be met. If I can just see our recommendations. Give me a moment. Firstly, that DOH takes immediate steps and regularly report back to the PPC and DCS to increase bed space in the affected regions with a view to the earliest possible transfer of all state patients to psychiatric hospitals or mental health facilities. In the interim, DOH to ensure that state patients detained in correctional facilities receive adequate mental health care and that DCS officials are appropriately trained therein. And we also have made proposals for changes to existing legislation. It seems to me that, in a sense, the genesis of the problems is that when there are not existing bed facilities in existing facilities, the courts have an option to refer such patients to correctional service facilities. And it says temporary, but unfortunately the temporary is not defined. So the temporary can run to a year or even longer. And so our proposal, which we've made to the South African Law Commission, is that either two options: either remove that option entirely, so the courts are not able to refer to state patients to correctional services. Alternatively, something which I prefer is that they can, if there's no bed in a mental health institution, refer that patient to a correctional facility for a maximum of 30 days. If after 30 days the patient has not been transferred to a mental health institution, the head of that particular facility must come back to court and get a different order, and that will be presumably to refer the person back to a Department of Health facility. But unfortunately, legislative changes, in my experience, don't take place overnight. And I would suggest that the efforts of all the parties, Department of Health principally, and the Department of Correctional Services, should be, and this committee, to encourage and pursue vigorously the notion of the Department of Health expanding facilities, bed bank. New hospitals don't have to be built. It might be a case of adding a wing, a ward. And when I hear that there's 380 million rand owing by the Department of Justice to the Department of Health, it seems to me if that only a part of that money were recovered, it would go a very long way to improving facilities at in the Eastern Cape and KwaZulu-Natal. Thank you. I've got nothing further to add at this point.
Thank you so much, Inspecting Judge, on some insightful inputs that you would have made to the Department of Health, because I think on this one, you are on the side of the Department of Correctional Services. It's happy to see you guys working together, side by side, agreeing on matters, and even pushing them together. It means 2026, it's a good year. We hope to see more of that. Members, were your questions, all of them that you have asked or clarities that you have sought, have they all been answered? Ms. Knaps, Honorable Niehaus, and Honorable Taibosh, these are questions. I'm going to stop you. If it's not a question that is not answered, we'll come to follow-ups after. So for now, it's questions that you would have posed that both the department did not respond to. Mrs. Knaps?
Thank you, Chair. So mine is to the DG of Health. I asked whether you agreed that state patients in DCS is harmful. I don't want to put words in your mouth, but I think you said yes. And then my follow-up to that was whether you agree that this means state patients should immediately be moved out of DCS into hospitals. And I noted that you were going to say you've got resource constraints. They've got all the same constraints, which basically cancels each other out. And the thing that we go back to is the well-being of these patients. Do you think they are better off in prisons, or do you agree that they need to immediately be moved to mental health facilities?
Honorable Niehaus?
Yes, Chair, one question that had not been answered. We did not get clear figures on how many foreign national state patients are currently held in DCS facilities.
They said they have nothing.
Okay.
Yes.
Well, unfortunately, that is a sad case, and I think it is necessary that they must provide the answer.
Yes, they did respond. There is no foreign nationals in state as state patients. I think all of us have
No
heard
foreign.
that.
Oh, okay.
Yes, so they did respond to that because I equally wanted that clarity. I was asking Sia. I haven't heard them speak, and as and when I was indicating, I think it's Mrs. Molepo who touched on the matter.
Okay, then I missed that. Thank you.
Honorable Taibosh?
Thank you, Honorable Chair. Mine was just in terms of the training, whether in DCS, as part of their training, are they being trained how to handle or how to deal with mental patients?
Those are questions that have not been answered, but I know that Honorable Taibosh's question was answered as well. I was telling Sia, members seem to be on, what do you call it, the weekend we're going to? The Easter weekend mood. Because I could see with how they, but your questions was equally answered, Honorable Taibosh, on that. But do we have any follow-ups, members, so that when the department comes to respond to also some of the issues that inspecting judge would have raised, they equally respond to your follow-ups? Knaps, you will be the first. Honorable Niehaus, you'll follow. There's no other person. Okay, then Mrs. Knaps, you can start.
Thank you, Chairperson. So I'm adding to the same question that wasn't answered. I just wanted to respect you and not add things before you invited us. So I just wanted to say, in your remarks, you mentioned, for example, that your budget has been going down for over a decade. That has happened at DCS as well. You mentioned that you've got specialized infrastructure. Prisons are also specialized infrastructure, right? You mentioned that you don't have the security expertise for those types of prisoners, but they don't have the psychiatric expertise. And you've got that funding that you mentioned, the ring-fenced, I think, for psychiatric services. So all of that is just to say, in your answer, please can you be thorough as to why, like I said, there are 400 of these patients, 437. Why should they be with 150,000 convicts versus 3,000? Whatever the hardship that will be imposed on the Department of Health from a humane and constitutional point of view, surely there is no other way to look at it except that they have to go to the Department of Health. So I'd like your response to that. National Commissioner, my second question is for you, because I don't know, I'm not feeling your energy here. We are defending you. Can you give your response to what they've presented? As far as I'm concerned, this is not, there's nothing useful in what they have said. It actually doesn't address the problem. Are you satisfied with the answers that you've received? That's my question to you.
Honorable Niehaus.
Yes, thank you, Chair. I'm going to follow up on where my colleague left off. I did not get anything from the Department of Health that indicates to me that they are going to take the necessary action in order to resolve this problem. I got a lot of reasons and excuses and financial problems, etc., etc. In the meantime, the Department of Correctional Services, that is the recipient department of state patients that are sent there, as far as I'm concerned, unconstitutionally and illegally. My question to the department is, I understand that the strategic plan for the department 25-2030 made provision for the department to refuse to admit a state patient referred by a court order. Will it be possible for you to implement this refusal mechanism? Will you activate it? Have you done so in the past? Were there instances where you have refused? And how many patients have been refused admission if you implemented such? You see, I listened carefully to what the inspecting judge of JIG said. He was saying that he prefers a proposal of a 30-day admission and then a reassessment. My view is a bit different. My view is that we will not make progress on this issue, and we will not get the Department of Health to deal adequately with this matter until they implement the clearly constitutional position that it is illegal to refer state patients to the Department of Correctional Services, and therefore that the department should not receive those patients, and that the necessary steps must be taken to stop it from happening forthwith. I believe it's unconstitutional, and I would like to hear from JICS what response they think should be taken also in terms of legal action to stop it from continuing to happen. Thank you, Chair.
Thank you so much, Honorable Niehaus. Acting DG, you would care to respond with the team, and then I think JICS will come in where it's necessary, and National Commission. O tla tsena le wena after. Ba o nyaka o bontsha hore go defenda wena today. So o tla emailela. Acting DG.
Yeah, thanks very much, Honourable Chair, and thanks for the questions. If we were sitting in the Health Portfolio Committee, I'm sure we would have a whole different set of questions than what we got here. And if we had the Health Ombud instead of the inspecting judge, you'd get a different set of opinions too. But let's focus on the patient. The ideal is definitely that a patient who needs healthcare should be in a healthcare institution. That is absolutely ideal, and I don't think that anybody in the health department would dispute that. Neither would our colleagues in any of the provincial health departments dispute that. But the point that I was trying to make is that if just by moving, by a stroke of a pen or by changing a law that forces a patient to go into a currently unprepared environment may not be better for that patient? I don't know because I don't work in correctional health facilities, and so maybe that's one thing we should do is spend a bit more time visiting the colleagues in DCS to see. But if you put patients like we've had recently, who are not even state patients, who assault one another and kill one another in the wards, threaten and try to stab doctors in the wards, rape patients in the hospitals, and we are not prepared to deal with those kinds of patients, and it happens all too frequently at the moment, we are not necessarily solving the problem. So I would caution against an all or none approach. Whilst I hear what the Honourable Niehaus is saying and what the inspecting judge is saying, yes, it is ideal. We should have more facilities, more capabilities, and the numbers are worrying that are going up from 100 to 200 to 400 and so forth. I think it's a question of putting our heads together. The short answer to your question, Honourable Member Nips, is that yes, patients who are ill should be cared for by health practitioners in a health environment. That's definitely the ideal. But in transitioning, we need to have a proper plan. If you just do it without proper planning, you are not necessarily improving the situation. So by way of commitment, we will certainly take this back to the National Health Council. I will obviously report to the Minister because he chairs the National Health Council. And the various matters on mental health that are already on the National Health Council agenda will just be added to by trying to address these. I've taken note of the very specific points that were mentioned about the Eastern Cape and KwaZulu-Natal. We are aware of some of those issues too, and they're probably the same, but we'll revisit the letters to see what the specific concerns were. I've already indicated the Eastern Cape province is in a particular difficult position at the moment. It's not just a matter of minor budgetary constraints. I mean, they have been decimated. So if we want to compare whose budget is worse, I'm not sure we're going to get anywhere. The Department of Health is taking, and I want to really say this directly to Honourable Niehaus, we are taking responsibility. We definitely take responsibility. And I tried to indicate that the Minister has been going flat out to try and get improvements. He was very unhappy about the way in which our mental health boards had deteriorated and not been put in place. And in fact, there's still one in the country that is still not fully capacitated, I think just one. But at the last National Health Council meeting, he again complained that we have not met all of the targets, but certainly way better than it was. Yeah, so I'm not sure that I'm going to commit further than that at this point, but we will definitely report back to the Minister and the National Health Council of the seriousness of the situation, as if, you know, although we already know that it is serious. Thank you, Chair.
Okay, thank you. Inspecting Judge.
Thank you, Madam Chair. There are differing views expressed here as to how to deal with this problem. One thing is clear, is that we do need to see real change, and we need to see that within a realistic time frame. I listened to Honourable Niehaus. I'm attracted at one level to his notion that if the gates are simply closed to the correctional facilities for state patients, then that will force the Department of Health to take positive and dynamic steps to improve facilities. But I'm being a natural mediator. I'm also concerned with the point that Dr. Crisp makes, namely that you could be making the situation worse if you're sending these people into facilities that are not ready to care for them. So that is why I think we need a program of action, concrete steps from the Department of Health, which will be put to this committee and which we can follow up on a regular basis. The worst, at regular intervals, the worst thing we can do is find ourselves back here in a year and the 407 patients is now 507 patients, and we get another presentation as to steps that are going to be taken and going to be taken. This is a human rights problem. It's a constitutional problem, and it needs to be addressed with the urgency that that demands. So I also think that one mustn't make too much of this. One's not asking for new hospitals to be built left, right, and center. You're addressing certain problem areas. With respect, the Eastern Cape and KwaZulu-Natal. And if those are brought into, if you can make substantial progress there, this problem will be greatly alleviated. And this is a doable situation. The Western Cape, you'll see from all these presentations, doesn't have one state patient in correctional facilities. If it can be done in the Western Cape with assistance and with ring fencing or conditional grants, where there's a will, there's a way, it can be done in KwaZulu-Natal and the Eastern Cape. So I would urge that we put this on the committee's agenda to be revisited at regular intervals, and ask the Department of Health to come up with concrete proposals and targets. Thank you.
Thank you so much, Inspecting Judge. National Commissioner.
Thank you, Honorable Chairperson. The latest that, as the National Commissioner, I have done on this matter was on the 19th of March, where I have written to the acting DG, who indicated that he does not have more than a month in the position. This is not the first letter. This is not the first discussion that we've had with the Department of Health. The matter is elevated to the cabinet cluster, the JCPS cabinet cluster. And we have also approached Treasury and written again to the Department of Health to say that this is what it costs us and we want to recover the money. So there are a number of actions that we are taking, but I want to go back to the comment by, or question by Honorable Niehaus. In the strategic plan, we are indicating that we will not refuse to admit state patients or mental health potential inmates. We're not saying that we will, we're saying we will not, because it will be illegal for us, because they come to us through an order of court. So, yes, I agree with the committee that there might not be that much of energy, but I want to request members of the Portfolio Committee, through you, Honorable Chairperson, to remember that the context also is overcrowding. Now, you have Department of Health with these issues. You have Department of Home Affairs. You have SAPS. You have the NDPP, you know, NPA. All of them have been, you know, approached, even in writing, for us to have a high-level team. And in the letter, for instance, to the Department of Health, I'm indicating that there should be a DDG, because we will put on our side a Chief Deputy Commissioner. And the task is that in the coming 100 days, we should come up with a comprehensive response to this matter. And that includes the review of the protocol, because there is a protocol, but this protocol was signed some years back. So as a practical result, it was signed in 2018. As a practical result, we will also review the protocol that all these departments signed up to. So in this 100 days, once the team is active, we will be answering the question that the inspecting judge is raising. I've already indicated that we've made inputs to the amendment of the Criminal Procedure Act. And on this one, I also would want to
to agree with Honorable Niehaus. Our input is simply that the option should be taken away. Because the 30 days, with due respect to the inspecting judge, the 30 days will just add another administrative burden to the system. Because it means now a head of center must go back to court. It would have called for, interactions with the Department of Health. We get the same response. There are no beds. We go to court, we get another order. The same thing that we do with the Department of Home Affairs. On the issue of deportations, you discuss with the department at a high level. Our heads of centers, they go to Home Affairs offices and try and work out the deportation processes to be more efficient. It yields results that, in my view, are very minimal as compared to the seriousness of the problem we are sitting with as a correctional system. I did indicate earlier on that that's not our work. We are not supposed to be handling or attending to mental health inmates or state patients. It's not our work. But the law enjoins us to do that. Our officials are trained to handle volatile situations. Before an inmate is accommodated, those observations are done by healthcare professionals. And the statistics speak for themselves with regards to their safety. But the more we do that, the more we expose other inmates to insecure environments. So we are under a lot of pressure, and the energies are divided across these departments that are sending departments or departments that are supposed to take these inmates out of correctional services as it is in their mandate. So yes, I might not be showing that energy, but this energy is divided throughout government, including Treasury. Thank you, Honorable Chairperson.
Thank you so much, National Commissioner. Naps? I can see by the smile, you want a bite. You're fine. Okay.
I'm also smiling.
No, please, don't take the shine of Mrs. Naps. Yeah, I think I understand your stretching, National Commissioner. It gets tiring. I think we also, in one of the oversight, I'm not sure if it's Limpopo, we got first-hand exposure to state patients to an extent that others were, their beds were on the floor. I think we equally also asked, why do we have inmates that are sleeping on the floor as opposed to on those beds, ideally for inmates? And we were told that it's because of they're not well. And there's a danger that if they're given beds, especially at night and so forth. We even asked in some instance, why are you having state patients or mental health inmates with other offenders? And we were told that it's to be able, other offenders to be able to also assist if something happens, and they will be able to take care of them. So in a sense, we're equally also putting the strain on offenders, on assisting the department in taking care of state patients, which is unfair. We're supposed to rehabilitate those who are incarcerated currently, but we're also adding on their rehabilitation to take care of other inmates. Because of that, we got to be exposed to when we're in Limpopo doing the oversight. First-hand of state patients in correctional facilities. So we're wrapping up in this way. We normally, acting DG, give recommendations as the portfolio committee that we want the department to consider and implement them. And in that instance, would also want to encourage a quarterly meetings between the two departments. You can include JICS as well. That you meet quarterly, or what works for yourselves as departments, as interdepartments, to try and mitigate the current crisis or a transition of state mental health inmates to psychiatric hospitals. So you must sit, find a plan and ways on how you assist one another, and you will come back to the portfolio committee and take us through that the current crisis that you came before the portfolio committee on, these are ways and systems we are putting in place to try and mitigate them. And based on these systems, already there are certain results that would have been yielded in that instance. So that perhaps we can see progress, because if nothing happens, the numbers are going to double as they have currently. I think at the policy level, the recommendation that the Department of Health has presented appear broad, mostly procedural, but they don't demonstrate a clear time-bound plans to resolve the current crisis, which is a worry. And I agree with Honorable Niehaus that you are not giving us solutions to the current challenges or crisis that you have. We understand the budget implications and so forth. I think all departments are having such crisis with budget cuts. But we should, within that allocated budget, prioritize certain elements. And as you really indicated, state patients are your solely responsibility as the Department of Health. Yes, the Criminal Procedure Act does enjoin DCS in this, but they are your responsibility, and you ought to take care of your responsibility. And this is not a technical issue. This is a human rights concern. It's a serious, serious violation of human rights. And as this portfolio committee, we can't turn a blind eye on it. Something ought to be done. And the persisting of state patients being incarcerated in correctional facilities, agreeing with the National Commissioner, it's also adding more to overcrowding. Yes, if you remove the numbers, overcrowding is still there, but it's another certain component that aids to overcrowding that we ought to look into. So it's very important that there is a coordination between the two departments to try and ease the burden or the crisis of the health system. On the legal framework, especially the Criminal Procedure Act, which inspecting judge would have spoken to, which talks to the temporary detention in DCS facilities, but effectively this has turned out to be now a long-term detention. It's no longer a temporary one. So it's a forever up until the state patient reach their minimum detention to leave the facility without even going through psychiatric hospitals. I think when we met the Minister of Justice, there was an issue of amending the Criminal Procedure Act. I'm not sure how far we with that. Perhaps there must be a submission from the Department of Correctional Services. Perhaps if as well I will implore Ms. Sowazi to look into it. We also as the Portfolio Committee make our submission to the Criminal Procedure Act on that matter, because of it is the one that enjoins DCS in having state patients in our facilities. And as the portfolio committee, we recognize this as a very sensitive matter. And as I indicated, we can't turn a blind eye. Yes, it's complex, sitting between the Department of Health and the justice system when an order has been issued that that particular state patient ought to be in a particular correctional facility. There's nothing that the Department of Correctional Services will do. It ought to act based on that order and create a bed for that inmate, whether it's a state patient or not. So I'm not sure how do we add justice in this coordination team, but there must be discussions between the three departments when that happens. Perhaps give timelines as well to say, whilst this particular state patient inmate is temporarily incarcerated in a correctional facility, put timelines 3 months. The Department of Health must have ensured that there is bed space availability in the nearest psychiatric hospitals. But that's a discussion that we ought to have with the Department of Justice. We note the challenges that results in delays to admit state patients to appropriate health facilities. We do note, and we really do sympathize with the department. We therefore recommend that there must be review of current legislation. And I would have talked to the CPA, the Criminal Procedure Act. I'm not sure in the health department which legislations are before the committees or the department, but we ought to find ways to review relevant legislation or amend certain provisions that would contribute to some of these ailing challenges that we have currently. And we also recommend that the Department of Health should consider attending or making submissions to the National Efficiency Enhancement Committee. And whilst you are sitting in those meetings, you will decide whether it's quarterly, but in a quarter you should give us an update of the two departments having met, and do kindly invite JICS to the table because they have been in the forefront on this matter. You also are able to talk to the stats so that your statistics can talk to one another. Yes, we understand that once an order gets to be granted from the courts, they directly talk to the Department of Health, whilst DCAS waits for a proper paperwork and so forth and so on, but they should, the stats should talk to one another. We can't have 407 and then the Department of Health talks to 430-something numbers. So the numbers should be the same because we are talking to the very same state patients. And lastly, the Department of Health should ensure that state patients that are detained in correctional facilities receive adequate health, mental health care. You would have, I think there was an indication that there are assistances that they get, especially Limpopo, I think Gauteng, some of the provinces that were mentioned where there is adequate mental health care that is given to some of those. But more importantly is to make sure that the officials, the DCS officials that are taking care of the state patients are properly trained. That should be your duty as the Department of Health. Yes, we have listened to the National Commissioner makes makes an indication that their officials are highly trained to be able to take care of any volatile situation. But that equally must be the Department of Health prerogative to make sure that those who are taking care of the state patients are properly trained and have the skills to be able to monitor and care of those patients. I would have spoken to your quarterly meetings, that you ought to, in a quarter, come back to us and give us update on them. And it must be a joint report. Then we will take it from there, whether there's a need to bring you back to take us through in the form of a meeting. So these are the recommendations from the portfolio committee that you would give updates to. And I think the matter of the Criminal Procedure Act will enter into that discussion if we do, perhaps in the second quarter when we come back from recess, have a bite again with any matters that relates to justice, to see if we can make our submissions to the matter. Yes, so we do appreciate you availing yourself, Acting DG, and the team from the Department of Health, even though the expectation was to get between the Minister and the Deputy Minister, whoever is available, to come through, but we do appreciate the time given to the Portfolio Committee to take us through the presentation, including answering to clarities and questions that members would have raised. National Commissioner, since Saturday, yeah, I think it's Saturday. I think it's Saturday. Raja will know. Only landed in the country Sunday in the morning. Then my phone was ringing non-stop. To such an extent, I had to switch it off on Sunday. With getting requests of interviews, of making formal submissions or hearing the Portfolio Committee's views on the interview that was done by ENCA with regards to Mr. Jermaine Prim. And I think I've read your statement as the department. Will therefore, as the Portfolio Committee, request a full investigation report once it's done on whether the call was from the public booth or it was a cell phone interview. And we're raising this on the basis that I think 2 to 3 weeks ago, we would have received a report from GITO with regards to telephone booth in facilities that do not work. But we know in Triple Ps and Zanini, those telephone booths are working. So I'm not sure with Johannesburg Correctional Facility, which is formerly known as Sun City, whether their telephone booths are indeed working or not. But that report must have that. And also the interview that was done within the protocols of having interviews. So once your investigations has been concluded, kindly do finish the Portfolio Committee with that report. Because we received, I think last month, we would have received a letter, it's not a letter, it's a court order, that would have made sure that as the Portfolio Committee, whilst we're playing our oversight, we ensure that you do honor the court order where you needed to transfer Mr. Jermaine Prim out of CIMEX, Hoshimampuru, to Johannesburg Correctional Facility. And we were given an indication that you did as such. But now with these calls and so forth, that has made even Raja to full-time come back to the committee now. would request you to be able to take us through all of that. Full investigation report, including, in the first instance, why Mr. Jermaine Prim was sent to CMEX, and whether is he still a remand detainee or he is convicted. Because of, I think there is no clarities on that. So those are the last on the matter, so that members don't, I think all of us have been seeing the interviews and so forth. We don't know whether how do we come in or not, because we're not privy. So we should be able, when we talk to the matters, we are equally as well informed to them, and whether the SOP that the department follows has been adhered to. So members, that brings us to the end of our meeting. Let me thank the Department of Health, the Department of Correctional Services, led by both the Acting DG of Health and the National Commissioner, JICS, led by the Inspecting Judge, for honoring the meeting and engaging insightful with possible solutions that we ought to take to make sure that proper placement of state patients, it's not in correctional facilities, but where they should be placed, which is psychiatric hospitals. So we hope those joint bilateral meetings will yield results in trying to find ways to mitigate the crisis. Members, there is transport arranged for yourselves, so you ought not to worry about the bus leaving you. There is lunch as well arranged, I think at the restaurant, so it's a sit-down lunch for everyone in the meeting. Then immediately after, the transport arrangement for members will be communicated whilst we're at the restaurant. So thanks once again, and please make sure that all of you remain safe when you enter your Easter weekend. Members would be back, I think, on the 20th or the 21st of April. And I know when we're back, we're going to be in the house for one day, then immediately after that, we ought to be on oversight. So the team will communicate where is our next oversight as the portfolio committee, because the second quarter when we start, we're going to start with an oversight. So the team will communicate where would the oversight be, including logistics towards that oversight. Abadimu le modimo ba nnele lena, ba le dire ka goloka, ene ba tsamaye le lena at all times. The meeting stands adjourned.